All right, everybody. Happy Wednesday. I think we're going to go ahead and get started. I want to wish every one of you a happy Wednesday and so glad to have you with us. I want to go ahead and call to order our meeting. This is the August Family Caregiving Advisory Council meeting. And of course, I want to start off by thanking each of you on the council for giving of your time and your talents to this incredibly important task of supporting America's family caregivers. And I'd also like to acknowledge and thank the members of the public who are tuning in to watch today's proceedings. Thank you so much for your interest and the support of our work. And again, it's good to have you on with us. So in a few minutes, I'm going to go ahead and share a video that we're excited about from HHS Secretary, my boss, Alex Azar. He made that to help us mark or commemorate this as our 5th meeting, but more importantly, it's been a full year. So this is our 1-year anniversary since we started in August of 2019. So we're going to show a video from the Secretary in just a minute. But first, I just want to, again, reflect for a moment on how pleased I know not only myself, but certainly our fellow council members have been to see the engagement and input from the members of the public. So your interest and enthusiasm for our work has certainly been an inspiration to us, and we value your input and feedback. So please do know that you're being heard and your input and your ideas will continue to support our efforts. And then of course to the members of the council, I cannot praise you enough. When we began this effort, of course, it really was from scratch. We had to sort of invent the recipe and pull together the ingredients and make some adjustments along the way, but now we're close to an interim report, and that's exciting that we'll be handing that off to Secretary Azar soon and offering him, of course, a full report in reflection of the work that all of you have done. So bravo, bravo. So thankful to all of you and your commitment, your work, your resiliency during the pandemic. And of course, I absolutely have to thank ACL's Greg Link and his team, Lori, Sarah, Cheryl, Chantal, and Clay. Again, it takes a team, and we have a great team here. And it's just so proud to work alongside these wonderful individuals. And as a personal favor, if you haven't recently, be sure to thank Greg and team, because they really pour their hearts and souls into this work. And of course, we also want to recognize just the wonderful collaboration that we have with our colleagues at the National Academy for State Health Policy, or NASHP. Those individuals, you know them, Wendy and Salam, Paige, and Kitty. Again, my thanks to those 4 just wonderful experts and so very helpful. And then another shout of thanks to our good friends at the John A. Hartford Foundation, of course, Ronnie and Scott Bain, just so grateful for their support and their participation. So our journey has truly, of course, been a collaborative one, as all of you know. And it's been that way since the president signed the Raise Family Caregivers Act into law on the 22nd of January in 2018. And I can assure you that Secretary Azar has been keenly interested in our progress and remains fully committed to making sure that our recommendations are honored and adopted to the extent possible. But rather than speak for him, this is a great opportunity for us to kick it over and let you hear from Secretary Azar himself. So with that, let's roll that video.
Good afternoon, everyone. It's wonderful to have the opportunity to address and thank the RAISE Family Caregiving Advisory Council as you hold your 5th meeting. When the Council convened for the first time in Washington 1 year ago, it was a significant step in a broad national effort to improve the lives of our more than 50 million family caregivers. We at HHS know that family members play a critical role in helping older adults and people of all ages with disabilities remain independent. In fact, over the past several years, I've helped as a caregiver myself to an older parent, and I've learned what kind of dedication it takes. That's true even when you're the Secretary of Health and Human Services, which means you at least know a good bit about the system you're working within. Our nation's system of long-term services and supports could not function without the dedicated daily efforts of family caregivers. Caregivers embrace their roles and find tremendous satisfaction in assisting their loved ones. But these efforts come with burdens too, and we recognize that family caregiving can strain the physical, emotional, and financial well-being of even the most devoted caregivers. That's why we're so glad the RAISE Act has asked us to engage family caregivers on these issues. The 5 words that form the RAISE Act's acronym make our mandate clear. recognize, assist, inform, support, and engage family caregivers. The RAISE Act was passed at a pivotal moment when we're seeing a significant shift away from institutional care and toward supporting older adults and people with disabilities who wish to remain in their homes. Simultaneously, our population of older adults is growing rapidly, and many of them will need care and support. At HHS, these trends are front of mind, and we recognize that family caregiving is central to adapting to them. I know that the team Lance Robertson has assembled at ACL is working hard to ensure that the voices of family caregivers are included in all aspects of our work. Lance has kept me up to date on the work the Council's doing, and your progress so far is impressive. In just 1 year, you've already issued an interim report, and I know there is much more great work to come. I look forward to reviewing your full report, submitting it to Congress, and helping ensure that its findings are widely read and implemented. My hope is that our initial report to Congress will present the voices of family caregivers in clear and compelling ways, helping to breathe life into the recommendations and strategies we propose. You will lay out a vision for our nation to better support our family caregivers, and together we will execute on that vision. Thank you for what you've done so far in that effort, and I wish you a productive rest of your meeting today.
All right, bravo. Yeah, that was nice, wasn't it? I'll tell you a couple things. One, no pressure at all when your secretary turns to you in a meeting and says, Lance, I need help with my situation with my parents, and I need your resources that we offer caregivers. No pressure. We got that to him. I hope it helped. Again, also, I think it's just important for you to appreciate that as secretary, despite the incredible volume of information that is sent to him, I promise you, when we send this final report over, he'll read it. Everything I've ever given him and anything my peer group gives him, he reads. He just is a real consumer of all of that type of information. So that's exciting. Do know that your work will be viewed by the Secretary of Department of Health and Human Services. I think, as all of you could tell, I mean, that message, obviously ties in with his support personally, but also it is genuine. And I think we're very honored to have a boss that really believes in this. And, particularly, even though videos like that may not take a lot of time, this is not a man that has a lot of extra time. Matter of fact, if you've been following, he actually now is leading the historic delegation to Taiwan. He has been there now for the last several days, and talked to him earlier today, and he's actually headed now to Alaska for some site visit work. So again, glad we got this video recorded, but I'm just really pleased that his support is absolutely there for the work that we're doing. So thank you. And, I really want to just close my comments by yet again just expressing that, we see the finish line. We know we're getting there. It's close. Now is the time to really, really lean in and to be honest and to share everything you feel is applicable and important to these conversations. Again, we're excited to see as we near that finish line how things are really shaping up, and it's taken a lot of work. So I thank you. So those are kind of the opening remarks, but now I want to go ahead and ask Cheryl if she would. Let's go ahead and do a roll call, please.
Okay, thank you. And for the record, our Chair, Administrator Lance Robertson.
Present.
Thank you. Our co-chairs, Casey Shillum. And please remember to unmute.
Cheryl, Casey had a conflict today, so
Okay.
she will not be here.
Okay. And I will say that there are a couple that have notified us, but some had changes in plans. Alan Stevens.
Present.
Nancy Murray.
I'm here.
And then for our non-federal members, Ben Bledsoe. Joe Caldwell.
Here.
Diane Caradu.
Here.
James Cheeley.
Here.
Gisela Dolan.
Here.
And I am sorry, Gisela Dolan.
You got it, Gisela. Here. Thanks, Cheryl.
Thank you. Thank you. Brenda Gallant.
Here.
Catherine Alicia Georges.
Here.
Rhonda Montgomery.
Here.
James Murtha.
Here.
Thank you. Deborah Stone Walls.
Here.
Teresa Tanus.
Here.
Carol Zernial.
Here.
And then for our federal members, Elizabeth Darling or alternate Liliana Hernandez. Linda Davis.
Here.
Bruce Fink.
Here.
Melissa Gerald. Melissa Harris. Helen Lamont.
I am here.
Tamara Mays. Lisa McGuire.
Here.
Jan Newsom.
Here.
Katie O'Callahan. Or alternate Diane Mitchell. Hector Ortiz. Rosemary Payne did also notify us that she was not able to attend. Mark Vafiades also notified us, but I believe Mark may have been able to join. Mark Vafiades? No? Okay. Joan Weiss?
Hi, Cheryl. Good afternoon.
Good afternoon. Thank you. Is there anyone that I did not call? Okay, thank you. Then I will turn it back over to Lance. Thank you very much.
All right, Cheryl, thank you. And again, thanks to all of you who carved out the time to be a part of this important conversation this afternoon. And like you, I really look forward to it. So with that, I'm going to go ahead and turn it over to Greg, who of course will run the remainder of the meeting. And Greg, thanks so much for your enthusiastic leadership. It's just an honor to work with you. Thanks, buddy. Floor is yours. Greg, are you on mute?
Yes, I am on mute.
Okay.
So yes, I just wanted to say thank you, Lance. I and my team, as well as all of the members of the council, really appreciate your leadership and your enthusiasm for our work. I think it helps us a great deal knowing your level of commitment to family caregivers and what we're doing. And so thank you so much. Let me just also add my welcome to the members of the council and to the public who are listening in. We have an action-packed afternoon ahead of us with a great deal to accomplish in a relatively short span of time. To the members of the council, hopefully you've had some time to look over the prep guide that we put together and sent to you all last week. And in doing so, you will have hopefully given some thought to two of our main agenda items today, which is revising our goals and then beginning in our subcommittees later on to beginning to develop a consensus on a set of recommendations that will ultimately become part of the report. But let's, speaking of our agenda, let's just go ahead and give everyone just a quick overview of what we're going to be doing today. Following a few updates from ACL and NASHP, we're going to hear from and have a discussion with Helen Lamont from ASPE, as well as Katie Brandt, the co-chair of the Napa Council. We've known for some time that the work that we're doing on behalf of family caregivers should really closely align where appropriate with what has been going on now for several years with the National Alzheimer's Project Act Council. And so we're going to hear a little bit from Helen and Katie, and then have an opportunity to consider where the recommendations that are developed, that you all develop, as well as how we can build out the national strategy later on, connect with, in a meaningful way, with the work of the Napa Council. Following our Napa discussion, then we're going to dig into the first tasks, which are first to consider a sixth new goal in addition to the 5 that we adopted back in February. And then we're going to discuss some suggested rewording of each of the existing 5 goals. As Wendy and I were working through all the input we received from you on the driver diagram and mulling and pulling out the draft recommendations we'll be working on later, it really became apparent to us that our goals needed a little bit of wordsmithing to ensure that they were both measurable and actionable, as well as very concrete. And so part of the prep guide that we sent you has the current wording of the goals, some suggested alternate wording that brings the goal without changing its meaning or scope, makes it more measurable in nature. And so we'll be working through that with you in a very structured way. And then once we've, and then we're going to also spend some time looking at a sixth new goal that we believe is important to consider including, just because of the breadth of the work that the driver diagram produced. We just felt that having a goal that speaks specifically to services and supports was going to be critical. And then once we've reworked the goals, then we're going to hold 2 votes via our polling feature, one to adopt the rewording and then one to adopt the new goals. So be on the lookout for that. And that's 2 of 3 polls that we'll be taking throughout the course of our meeting. And then this is where our meeting will become a little different from previous ones that we've held of the full council, at least since our first gathering back in June. Following our work on the goals, the public portion of this meeting will end, and we'll take a short break. And then we will reconvene in our subcommittees, all on our meeting platform here, and you all should have received a second link. All of the council members should have a second link to those subcommittee meetings, and you will then work in your subcommittees on beginning to work on some of the recommendations that will be included in the initial report to Congress. And so I'll be giving you a bit more instruction on that when we get to that portion of the meeting. Any questions at all about how our meeting will flow today? Okay. Just by way of some updates, I've got a few from ACL, and then I'll turn to my good friend and colleague at NASHP, Wendy Fox-Grage. Since we were last together in July, and it's hard to believe it's been a month already, but so much has happened on a variety of fronts. The ACL and NASHP team has been hard at work, and we're making real progress, particularly on drafting the initial report to Congress. As you'll recall, our approach has been from the very beginning for that at NASHP and ACL, our team members would draft develop drafts of products and materials, and then workshop those drafts with you, either in your subcommittee meetings or here in full council meetings, depending on what the situation demanded. This is the approach, for, if you remember, that we used back in February when we suggested some initial goals and guiding principles. And it seemed to work out pretty well. You all responded extremely productively and extremely well to what we were proposing as drafts, and then you took them and made them your own. So we're continuing in that vein as we begin formulating the recommendations later today, but also as we begin pulling together the initial report to Congress. And speaking of that report, we have made some real and significant progress on that draft. Sarah Markell, who's the newest member of the ACL team, on this project, has undertaken the lead in the writing effort. To date, she has the intro and the background sections well drafted. She's begun incorporating the information from the Medicare paper that we had a presentation on last month by Judy Stein and colleagues from the Centers for Medicare Advocacy. And she's now working on the analysis of the RFI that we also heard about last month that the University of Massachusetts in Boston spoke to us about. The RFI analysis is fantastic. We just got the pretty much a final rough draft last week, and it is being used to infuse the voice of the family caregiver throughout the report. We're still going through that draft and working with the UMass team, and we're going to send it to each of you next week after this meeting is over. We believe that the RFI analysis is going to prove very useful as you continue your work on formulating the recommendations for the caregiver report. We also have a series of caregiver snapshots that we're calling that are in the works. Thanks to the efforts of NASHP working with a sub-grantee, the National Alliance for Caregiving. These snapshots are going to provide some real in-depth portraits of real caregivers that we plan to incorporate throughout the report. And then our Health and Aging Policy Fellow, Laurel Traylor, has completed her initial drafting of the inventory of federal programs. And that has also gone to Sarah Markell to begin incorporating into the report. and she's now working on a very high-level analysis of the information we gathered from our federal partners to begin pulling together the overview. I just, again, have to say a big thank you to our federal partners for getting us the information we needed for this part of the report. We are going to be reaching back to you from time to time as we fine-tune and edit the material that you sent to us to make sure that it fits into the overall tone and tenor of the report, that we have the information that we're presenting exactly correct, and that it shows to the fullest extent the work that each of our federal partners is doing on behalf of supporting family caregivers. And then in a minute, you're going to hear from NASHP about a couple of other elements of the report that are coming together. Finally, I just wanted to let you know that a little bit later this month, I'll be authoring a blog, for an ACL blog, highlighting our first year of work and the accomplishments of the RAISE Council thus far. And I'm going to begin working on that after this meeting. And so I think it's a really nice way to sort of mark our 1-year anniversary, 1 year of our work, as well as to look ahead into the near and a little bit longer term, the work that we have ahead of us. So that's it for me. Wendy, did you want to go ahead and provide some NASHP updates?
Sure, sounds great. Good afternoon and good morning to some of you, depending on what time zone you're in. It's great to be on this meeting today. I have 3 updates to add to what Greg just said, but first a very quick thank you and acknowledgement to the John A. Hartford Foundation for their generous support, and in particular to Ronnie Snyder and Scott Bain for all of their guidance. And as Greg said, we've got a fantastic partnership with ACL and my colleagues at NASHP, Kitty, Paige, and Salam. So thank you, thank you. So 3 quick updates to add to what Greg said. And as what Lance said, is that one of the primary elements in this report to Congress that's been so important to the council again and again is to make sure the voice of the family caregivers are heard throughout the report and even throughout your whole process. So as Greg just updated you about the RFI analysis, you will be getting that written report very soon from Dr. Nadash from UMass Boston, who presented to you all, but you'll have it in writing, as well as the family caregiver vignettes that NAC is working on. In addition, we've had the many listening sessions of family caregivers, and those have just been fantastic. We've done 10 of them so far, and there are more to come. So hopefully council members have been able to listen to those live, and if not, everybody should have links to the recordings of those. And just to give you a heads up, we will send you, the council members, we will send you invitations to the upcoming sessions and of course those recordings as they happen. 2 more quick items. We're about to have a faculty meeting. There's a wonderful faculty of advisors who inform this project. They're going to be meeting on September 3rd. They're going to help continue guiding this work. We're going to give them the draft outline that the council members received last month. We're going to have them take a look at that, give us feedback, as well as the recommendations that you all go over today. We'll incorporate their feedback for the council's review. So just a heads up, the council members will be getting that as well. And then lastly, my organization, NASHP, is going to be writing a Medicaid paper on family caregiver supports. Last month, you all heard from Judy Stein, who wrote for the council and for the report to Congress, a wonderful report about Medicare. This is going to be the complement to that, but on Medicaid. So we are in the process of writing that now, and we will, as soon as possible, when it's ready, we will get that to the council as well for incorporation in the report to Congress, because it was actually laid out even in the RAISE Act, that's an important element, both Medicare as well as Medicaid. So I think it's all coming together very nicely for this report to Congress. As Greg said, we've got a lot of moving pieces, and as they are hot off the press, we will be sending them as they're ready for review to the council. Greg, back to you.
Great, thank you so much, Wendy. Any questions for either Wendy or me on anything that we've gone over as far as our updates that we have for you?
Greg, thank you, and Wendy. Could you please, this is Linda Davis from the VA.
Sure.
Could you please let us know when the inventory might be available? Will that be only provided as part of the entire report, and when that's submitted? As you know, we have a federal advisory committee for veterans, families, caregivers, and survivors.
Mm-hmm.
And that was actually one of their recommendations. We deferred because knowing that RAISE would be putting this together. The other is we would love to get your blog when you have it out to be able to share that broadly with the 5.5 million caregivers of veterans and service members, to brag about the great work this task force is doing.
Definitely. Once the blog is published, and we're hopefully going to get that out by the end of this month. Linda, I will make sure that you receive that ACL Gov delivery, so that then you can forward it on to whomever you like. And yes, the federal inventory that we're working on, each one of our federal partners will obviously have to vet what we draft from all of the great information that you gave us. So that will be your first opportunity to look at the entirety of what it is that we collected and sort of how every organization is reflected in it. But then by all means, the inventory, the way it's coming together, and I think the way we're envisioning it will be that it provides summary snapshots of each of the federal partners and the agencies that work on, have something going on that in some way touches the lives of family caregivers. But we're also looking at an opportunity, perhaps within the appendix of the report, to include a more detailed look, kind of for all of the wonks and the nerds out there who really want to dig into what's going on with every agency. We're looking at a way that we can present the breadth of what you all gave us in a way that might be a bit overwhelming for some, but for others it may be just exactly what they're looking for. So yes, that will be available.
Thank you very much. I'd just like to offer for everybody on the call, whether it's government or non-government, that we reach almost 12 million veterans every single week with a really powerful and well subscribed letter. And so if you have any content, services, anything you want to share for the benefit of caregivers and their family members, we're glad to insert that. So thank you very much.
Great. Thank you so much, Linda. Any other questions or comments for Wendy or me? Okay, well, then we are going to jump into I wanted to just ask, Ronnie Snyder or Scott Bain, I cannot forget the two of you, our wonderful collaborating partners at the John A. Hartford Foundation. Any updates or things you want to share with the group before we move on?
Hi, Greg. This is Ronnie. No specific updates. We're really particularly excited to hear the presentations today around Napa, which is a great sort of parallel track and something that we all can learn from as well. So looking forward to that, and just thank you so much for all the great work that's happening.
Thank you. Well, Ronnie, you just provided me with the perfect segue. So I'm going to go ahead now and turn this portion of the agenda over to Helen Lamont from HHS's Assistant Secretary for Planning and Evaluation Office, and Katie Brandt, who's a co-chair of the Napa Council. They're going to be talking with you all about some potential intersections between their work on the Napa Council and ours here on the Family Caregiving Advisory Council. So without further ado, I'm going to hand it over to Helen and Katie.
Thanks, Greg, and thanks so much, everyone, for having us here to present. Again, my name is Helen Lamont, and I am the DFO, or Greg's counterpart, really, on the National Alzheimer's Project Act Advisory Council on Alzheimer's Research, Care, and Services. I'm also a member of the RAISE Council, and I have presented a little bit on the Napa Council before, so some of this might be redundant, but we're excited to be here to talk about more specifically where the parallels are in our recommendations and how we can work together with the RAISE Council to amplify the voices of both of the groups. And today I have with me Katie Brandt, who is the co-chair of our advisory council, as well as a caregiver. So Katie, would you mind introducing yourself?
I would love to. Thanks, Helen. And thank you for having me as part of the meeting agenda today. This is a topic that is very near and dear to my heart. In addition to being co-chair of the Napa Council, I work as Director of Caregiver Support Services for the Massachusetts General Hospital Frontal Temporal Disorders Unit. So in our clinical research program, we're caring for individuals with rare, young onset, and atypical forms of dementia. And my role is to work with the care partners. I became connected with this work not only because of my love of community-based and policy programs, but because I am a former caregiver to my late husband, Michael, who passed away after a battle with frontal temporal degeneration at the age of 33. Around the same time that my husband was diagnosed with FTD, my mother passed away unexpectedly, and that left my father in need of a caregiver himself, as he was diagnosed with Alzheimer's disease in his late 50s. I've now been a caregiver for my father for 11 years, and I think that the role of caregiving for someone with a young onset atypical dementia, as well as someone with more of a, of course young, but more of a typical Alzheimer's presentation, in addition to being a professional and a single parent, has exposed me to a lot of the issues that caregivers face. And Linda, I just need to give a shout out to the VA, because my father is a Vietnam veteran, and I myself received the caregiver resources from the VA, and they are in fact wonderful. And I've benefited from that. So I hope that not only can I speak about our recommendations today, but that I can share my passion about the importance of family caregiving, and share a little bit at the end about what caregivers are talking about now during the pandemic.
Thanks, Katie. We can have the next slide if you all don't mind. That was our intro slide. So just, let me check, just really quickly, many of you have heard this before when we talk about Napa. You know, when you start working with the government, you start to hear lots of acronyms and you're sometimes not sure what they all stand for. So Napa is the National Alzheimer's Project Act. It has a nice ring to it, so we often call it Napa. It was signed into law in 2011, and in many ways it's very similar to the RAISE Act. It calls for HHS to, among a couple of other things, create a federal advisory committee to make recommendations to address Alzheimer's disease. And I should just stop right there and say Alzheimer's disease refers to Alzheimer's disease and related dementias. So we sometimes go between Alzheimer's disease, dementias, and ADRD. For the scientific biomedical purposes, there are differences, but in terms of care and services, we kind of use those terms interchangeably. So the Napa Act calls for us to create our advisory committee to make recommendations, to create, maintain, and update a national plan to overcome Alzheimer's disease, and to regularly report our progress, and the federal government to report the progress. So like RAISE, we have an advisory council that includes both federal and non-federal members, and I think I've mentioned before how productive that structure has been for us. We meet quarterly by statute, and we've been doing so since September of 2011, and the only time we ever missed a quarter was this spring when we chose to cancel our meeting due to the pandemic and the impact it was having on our members and the people that they serve. And in July of every year, including this year, the council makes annual recommendations, and I'll get into them in just a moment. We're also required to, or we're required to create and annually update the national plan to address Alzheimer's disease. And that was first released on May 15th of 2012 and has been updated annually since then. And we expect that the next update will be released in October of this year. Next slide, please. So our recommendations, according to statute, are transmitted to the Secretary of HHS and to Congress. They help to inform the Secretary's policy priorities and the development of the next iteration of the national plan. The recommendations are also used on the Hill often by our non-federal members or the stakeholder groups that support our work to inform lobbying efforts, federal funding and policy priorities. And some of our advocacy organizations actually will take the recommendations and put them into the materials that they are sharing on the Hill as part of their advocacy work. Similarly, we know that some organizations use the recommendations at the state level to advocate for change. So although we don't explicitly send the recommendations to the states, there are sometimes recommendations that are directed to the states because that's where the policy levers are. And if we want to see changes, the states need to change what they're doing. We're also very clear that this is a national plan and not a federal plan, despite being staffed mostly by federal staff. So the council has chosen to include recommendations that go beyond what the secretary and Congress can do. And now almost every state has an Alzheimer's plan or a dementia plan. I think there's one outstanding state, and many of those were informed by our national plan and or by the recommendations of the advisory council. Our recommendations, of course, are shared with the public on the Napa website and should be posted this week. The presentations from the last meeting are already posted, so you can see our recommendations there. And we've even been told that there are international bodies that are looking to our recommendations and our national plan to see where our priorities lie and what next steps we identify. Dementia, as you can imagine, is a global issue, and while a growing number of other countries have Alzheimer's plans, many do not. And there's efforts underway to coordinate internationally in that space. So all of that is to say that similarly, we would expect that the recommendations from the RAISE Council wouldn't just go to the Secretary and to Congress, but would be used by the stakeholders involved in the RAISE Council, the advocacy community, to further the work that's needed to support family caregivers. Next slide. So just very quickly, I wanted to go over what Napa covers, and then we'll talk a little bit about how it's similar and how it's different from RAISE, because I think if you take a cursory look at the Napa group, you might think, oh, there's not a lot that we have in common, but there's definitely places where we can work together and where our issues are very similar. So Napa is organized a little bit differently from RAISE. We have 3 subcommittees that are somewhat overlapping, one on research, one on clinical care, and one on long-term services and supports. In our 5 goals of the national plan, the focus is on research to prevent or find a cure for dementia, improving the quality of care received by people with dementia, making sure there are supports in place to support people with dementia and their caregivers, enhancing public awareness and engagement of governments at all levels, and tracking our progress. And so family caregivers mostly come into focus as part of the long-term services and support subcommittee and the work underway as part of goal 3, but we really recognize them as essential to successful biomedical research, high quality care, and our public awareness efforts. Next slide. So this is a more parallel between Napa and the RAISE Council. In many ways they're similar, but there's also important differences. So of course our populations overlap. About half of all people providing care for an older American are taking care of somebody with dementia. There are higher rates of financial, emotional, and physical burden among dementia caregivers than other caregivers, perhaps because dementia caregiving is often very high in intensity and very long in duration. On the flip side, some people who are caregivers of younger people are themselves at risk of dementia. And we do a lot of work with the Down syndrome community and people with intellectual disabilities who are at higher risk of dementia as well. And there you have a caregiver and a care recipient who both may be at risk of developing dementia. Of course, Napa recognizes as a core component that caregivers are essential to the health and the well-being of people with dementia. And from our very first conversations about Napa, we have always talked about caregivers as essential. We recognize the importance of integrating caregivers into the healthcare system, as well as the need for affordable, accessible, and culturally competent long-term services and supports. As you know, the vast majority of long-term services and supports in this country is unpaid care provided by family caregivers, but those paid supports and funded supports need to be there to support the family caregivers as well. We also both seek to advance research on care models and interventions that can support the family and address the caregiver's needs. We often talk about person and family-centered plans. In terms of differences, of course, our #1 goal is to prevent or effectively treat Alzheimer's disease by 2025. This is different from RAISE. No one wants a world without family caregivers. So our approaches might be different because the Napa Council seeks to eradicate a disease, while the RAISE Council is working to better support what is an essential part of family life. Although there's great diversity in caregiving and caregiver experiences among people who care for those with dementia, RAISE includes and represents even greater diversity in the conditions, the ages, the challenges, the opportunities faced by the care recipients, and that lead to different caregiving roles, perspectives, and possibly solutions. The Napa Council focuses on a few areas that RAISE would not, most notably biomedical research, of course, diagnosis and clinical care for people with dementia. And finally, as Napa has evolved over time and more stakeholders have become involved, we've actually added more initiatives driven by persons living with dementia. So we don't just talk about training caregivers anymore. We talk about training people living with dementia and their caregivers. That's a change from the beginning. In the beginning, we talked about just supporting the family caregivers. But over time, the voice of the people living with dementia, including members on our council, have become very strong. And they have shown us that we really need to incorporate them as individuals and as people who have a perspective in all of the work that we do. Katie, is there anything that I missed here that you'd like to add?
No, I think you did a great job. And it's wonderful to see all the similarities just laid out there to show how strong our work can be when our voices are united.
Oh, thank you. Next slide. So I'm going to do just a quick overview of where we are in our process with our recommendations, and then I'll turn it over to Katie to walk through those recommendations. So our most recent meeting was on July 20th, when our subcommittee chairs presented their recommendations to the full council for adoption. All of the non-federal members voted to approve the recommendations, and they, as I mentioned, will be posted on our website this week using the link that is here. As I said, these recommendations will go to Secretary Azar and will be transmitted to Congress. And the federal agencies will refer to these recommendations as they identify new actions for the 2020 update to the National Plan to Address Alzheimer's Disease. So now I'll just turn over to Katie to walk you through the relevant NAPA recommendations from this year. And then we look forward to discussing with you all how we can work together and align our recommendations going forward.
So next slide, please. Yeah, so Helen just gave, I think, a tour de force there of an overview of what is the Napa Council and the recommendation process, and it can feel overwhelming. So, of course, because one aspect of our subcommittee recommendations is most relevant to the RAISE Council activities, but also just to break it down and really talk about what do the recommendations look like, so maybe to help your own structure and setup. So we wanted to start with this slide. It gives sort of an executive summary of the 2020 Long-Term Services and Supports Subcommittee recommendations. And I just have to take a moment here and thank Deborah Cherry. She's the chair of our LTSS subcommittee, and she, along with other members of the subcommittee and myself, put an incredible amount of attention and work into each recommendation that I'll talk about today. So as this is an executive summary of, I think, you know, the top 5 recommendations from LTSS, and then I'll go into more detail of the first 3 that are most closely aligned with the RAISE work. So the first one, just decrease disparities and expand access to LTSS, including home and community-based services. This is an example, and you'll hear me talk about this multiple times throughout the rest of my presentation, about a theme or an overarching philosophy or platform or value that can be integrated throughout a recommendation. Because of course we want to decrease disparities and expand access. And so we'll think about all the different ways that we can do that. We want to improve integration of clinical care with home and community-based services, including systematic identification, assessment, support, referral, and engagement of persons living with ADRD and their caregivers by healthcare systems. Recommendation 3, to provide high-quality, person and family-centered long-term services and supports. So Helen mentioned that this is the language that we try to incorporate over and over again. That person and family-centered care planning recognizes that each person has unique resources, family members, communities, culture, and values. And so while one individual may want to make a care plan that is centered around the things that they will do and they will drive as an individual, another might have a cadre of very involved family members and friends who want to help with their care plan. And then that's a way to recognize the intrinsic personhood and dignity of the person living with the diagnosis. And then 2 recommendations that are probably less aligned with the work of the RAISE Family Council is that we will address behavioral and psychological symptoms of ADRD across care settings, and we will prepare the nation to reduce risk factors thought to lead to ADRD. And I think that gets back to, again, that we are looking with at individuals who need care for a specific condition, whereas the RAISE Council, you're going to have such diversity in that. Next slide, please. Okay, so our recommendation 1, again, a great example of how we can think about including this theme, broad-based and across multiple recommendations, to decrease disparities and expand access to affordable long-term services and supports, including home and community-based services. By 2025, programs beyond Medicaid that provide LTSS should be expanded to support individuals and their caregivers with unmet needs, including diverse, underserved, and high-risk populations living with ADRD. So really calling out the most vulnerable members of our population that are receiving that caregiver support, that they need special attention. State models for expanding the availability of LTSS and/or supporting unpaid caregivers through 1115 waivers and other strategies should be evaluated by ASBE and, if warranted, disseminated broadly to encourage adoption by other states. And then we provide a link for a toolkit. As I go through these next bullets, it's a great example of how the recommendations are tailored to different groups, which I think then speaks to the national plan, right? That we're not just talking to one entity with our recommendations. Congress should expand the Family Medical Leave Act, and states should expand supports for paid leave for caregivers. States should expand voluntary long-term care savings accounts. Congress and states should expand tax credits for caregivers. So when you look at all of those sub-bullets, they support the recommendation of, by 2025, programs beyond Medicaid will expand to support individuals and their caregivers that are at risk in those most vulnerable groups. And then we have expand access to home and community-based services through healthcare providers and systems. That Congress should sustain Section 2404 protections against spousal impoverishment in the Affordable Care Act and the Section 1915 HCBS state plan option, community first choice, attendant care services and supports, and individuals eligible through a medically needy spend down to HCBS waivers. That is so incredibly specific. And that's again why you need these experts sitting on your council to provide that type of input for very specific action-oriented directive recommendations. Next slide, please. So the second recommendation that we think aligns with the RAISE Family Council is to improve the integration of clinical care with home and community-based services. So really thinking about, we started this conversation because we wanted to think about, we don't want people to receive clinical care over here and then go home to their communities and engage in services that provide them with the supports that they need on a daily basis, but how much integration can we have there? So by 2025, hospitals and healthcare provider practices serving people living with ADRD will have in place procedures to identify and document a caregiver or authorized healthcare proxy where appropriate, to participate in care planning and better assure goal implementation. I love that the R in RAISE is recognize, and I think that it really gets to the role, the essential critical role that caregivers are playing, in that they want to be seen as critical members of their loved one's care planning team. And this is a way we can do it. To co-design person and family-centered care plans with the individual and caregiver or authorized healthcare proxy where appropriate, so that plans are concordant with the individual's goals of care and can be supported in the community or other long-term setting. This is critical to recognize the unique cultural values, goals of care, and even resources and challenges that individuals may face. When undertaking discharge planning from a facility, the individual living with ADRD and a caregiver or authorized healthcare proxy should be involved so as to lessen the risk of rehospitalization or other adverse events. So really taking into consideration when someone is being discharged, what will their home environment be like? Is the caregiver ready to receive them at home if there are new challenges or issues that need to be supportive? And really making that a conversation. Assess the person living with ADRD and the caregiver's long-term services and supports needs. Provide them with disease education, caregiver training, and home and community-based services, and/or refer them to community-based services. This should include information about costs and coverages for these services. You know, this bullet specifically, I think really speaks to where we could overlap. So when you think about caregivers needing disease education, training, and connections with community-based providers, that would work for so many caregivers and is not individually specific to dementia caregivers.
Katie, can I just jump in on that one?
Yeah.
So I think it was last year, although you know how time is so strange now, could have been 2 years ago. There was a hearing on the Hill, and I think it was focused on diagnosis for people with dementia. And one of the members asked the speaker, who was a family caregiver, what she wished she had known or been told when her loved one was diagnosed. And she said, I wish I had known what we needed to do to qualify for Medicaid. And of course, the doctors in the room said, that's not what a physician provides. So I think that just underscores here that families need other information that is not what the neurologist is going to give them or someone else is going to give them in a clinical setting, but it's sort of essential as they plan for what to do next and how to move forward. And that's recognized here. And then certainly, as you said, the RAISE Council can underscore the need for those services and supports, but linking them to those who are providing the diagnosis.
I think it just speaks to this need for training. It's, you know, I just gave a presentation to our neurology fellows and I reminded them, when you are diagnosing someone with dementia, you're actually giving a dual diagnosis. That when you diagnose someone with dementia, you're likely diagnosing somebody else as a caregiver, and that they need this new toolkit. They need new information. So that's a great example, Helen. Thank you. And then the last one, by 2025, CMS will have quality measures in place that will encourage healthcare systems to implement these recommendations. I want to pause for a minute and really just take a moment to look at this bullet. So this is a big one, right? And something that may be difficult to achieve. Deborah Cherry has been an amazing leader to coach us in the subcommittee that it is our role as non-federal members to submit recommendations that are sometimes aspirational, that are things the way that we wish that they would be. And that will help to drive policy and actions forward. And that it may take time to achieve our big goals, but that it is worth it to be aspirational, even if it seems pie in the sky at first. Next slide, please. Recommendation 3, to provide high quality person and family centered long-term services and supports. This is so important. Research should be funded through federal agencies and other public and private funders to study the implementation of evidence-supported dementia and caregiving interventions. Federal agencies and other public and private organizations should disseminate evidence-supported interventions and person and family-centered care planning models. Federal agencies and other organizations should convene representatives from professional societies in an effort to develop and harmonize practice guidelines as pertains to care planning, caregiver support, and HCBS recommendations across the evidence. To expand the applicability of evidence-supported interventions for people living with ADRD, and for caregivers from diverse, underserved, and high-risk populations living with dementia. So before I continue with those bullets, which continue on the next slide, I just want to pause for a minute and point out that we're talking about evidence-supported, evidence-informed, and what are the best practice models. And that what would be important is that people would know which are the models that have that evidence base, what has been shown to be good practice, and then allow people to choose things that are going to be the best fit for their community, taking into account, again, diversity, culture, and socioeconomics, resources, resilience, and challenges. And I think that there is a real movement that people want to have these models presented to them along with evidence. So as we look at the last recommendation and we're thinking about expanding the applicability of evidence-supported interventions, we want to, number one, establish a repository of assessment and outcome tools and instruments that have been validated for use with culturally and linguistically disparate populations. And next slide. And that federal agencies, states, and other organizations should build workforce capacity to provide dementia-capable long-term services and supports, including training on person and family-centered care planning and evidence-supported interventions for people living with ADRD and their caregivers. CMS and other federal payers should create care and payment models for use of effective evidence-supported interventions for people living with ADRD and caregivers, as well as for person and family-centered care planning. So training our workforce, building up our frontline heroes, those essential workers. I mean, the pandemic has shined a spotlight on what many of us in this field have already known. And then also thinking about how can there be a pay system in place for those models of care. Next slide, please. So this is something that was really exciting and came forth unanimously from our council this year. So as Helen described, the 3 subcommittee structure of our council, and that recommendations are usually presented by subcommittee because they're specific to that topic. This year shined a spotlight on 3 issues that we felt were so important that we needed to present them right up front as cross-cutting recommendations that would lay the foundation, build a platform for every other recommendation after that. And those 3 cost-cutting recommendations are in the areas of health equity, emergency preparedness, and risk reduction. So the first one, the Department of Health and Human Services and federal partners should improve and expand emergency preparedness, response, and recovery with specific consideration of the needs of individuals living with Alzheimer's disease and related dementias and their caregivers. Second, the Advisory Council and federal partners should develop a national goal to reduce the burden of risk factors to prevent or delay onset of Alzheimer's disease and related dementias. And the third, advance health equity by addressing racial and ethnic disparities in Alzheimer's disease and related dementias. And I want to emphasize that even though the events of 2020 have shined a spotlight on the importance of these issues, that these are in fact timeless issues for families living with dementia and for caregivers, that these are things that we would always want to work on. I think, unfortunately, there will always be a tornado to think about. We will always want to think about where are the areas where there are disparities and gaps in opportunities and services. And then risk reduction for our specific population will be something that we will continue to talk about. Next slide, please. So key opportunities for caregiving. To improve long-term services and supports, federal support is a significant ask, but opportunities to assist caregivers through improvements to Medicare and Medicaid. We could educate states about models of excellence in long-term services delivery and financing, caregiver assessment and support, which means, really understanding what does this caregiver need? One size fits all isn't going to work for caregivers. Evidence-supported caregiver interventions, and home and community-based services provisions. Areas for joint aligned recommendations include disparities in service access that we should both address, protection of caregiver financial security through tax credits, long-term care insurance financing, etc., and improvements to Medicare and Medicaid. Next slide. And Helen, I will turn it over to you.
Great, thank you, Katie. So one thing I should have said up front is that, we've been going through this recommendation process. I guess this would be our 9th iteration because we did have recommendations before the first plan, and things have changed over time. So don't feel pressure to format your recommendations similar to how we have them. They certainly have evolved over time, become more specific, and in many cases have continued to underscore issues that were not previously addressed, so that the message was really amplified. So we see some key opportunities for collaboration with the RAISE Council to reference and amplify each other's recommendations. The Alzheimer's Council is not able to give as much time, of course, and attention to the caregiver needs as you all are. And I know many of our council members were looking forward to seeing your recommendations so that we can reference them in our recommendations in the future. Certainly cross presentations like this one are helpful, and we're in the planning process for our October 2020 Napa meeting and would welcome someone from this council to present at that meeting. It's also focused on long-term services and support, so it's certainly a timely topic. We also want to encourage you all, and then we'll do the same, to build off the research accomplishments. Perhaps our greatest the greatest metric we could track for the dementia work has been the massive increases in research funding. And we're thankful to our colleagues who have ensured that that's not just funding to find a cure, but funding for caregiver supports, caregiver interventions, assessments, data collection, et cetera. So there's a lot happening in the research space that we hope that you all can build off of and move forward. We have shared membership and commitment by federal staff. So not only myself, but Lisa McGuire, Joan Weiss, and Bruce Fink are both members of both of the councils. And I know in our conversations, we've talked about moving both councils forward and building off of what the other one is doing. And I think the final point to make here is that even though much of the Napa work is focused on treating or preventing Alzheimer's disease and related dementias, that we really see that if we're able to reduce the burden of the disease, that it would alleviate suffering, not only for people with the condition, but it would make things a little bit easier for their caregivers. And so hopefully we're able to achieve that 2025 goal, and there can be some shared successes and reduction in the burden on family caregivers for people with dementia. And then Katie, just want to turn it over to you as a caregiver and for the last word.
Yeah, so I think that the pandemic has given us new reasons to recreate some of our caregiver supports. And so through my work at the Mass General FTD unit, I've been doing weekly caregiver support groups with co-facilitators and FTD, early onset Alzheimer's, and other dementia caregivers. So every week we've been meeting for an hour over Zoom. We call them Caregiver Support Tuesdays. And we talk about many different topics. So sometimes our meetings are very emotional, where we're maybe talking about grief and loss, frustration, challenges. And other times they're very practical, like where can people get information about how they can access other support services? How can they bring a home care provider into their home safely? Or sometimes they have a lot of disease questions, like what is the next stage for my loved one? What will they need? And I thought that it was really interesting. I had a caregiver say during a recent meeting, I need information. He needs hope, referencing her loved one. And I just thought it was such a striking example of really wanting to focus on the individual needs and goals of care for each family that we're working with. And that if we can take the time to listen to our caregivers and our persons living with a diagnosis, then they'll tell us the things that they need. And I hope that through our roles as supporting policy and as professionals in the field, that we can just create those opportunities so people can access the services and supports that are the right fit for them. So thank you everybody for having us today, and we're thrilled to be a support and a help in any way.
Yes. Yes. Thank you. And will you fast forward to the next slide? It's just the link to our website. For any more information you need, there's a lot on there, and it's not super pretty, but feel free to dig in.
Thank you, Helen. Thank you, Katie, both so much for this. This is something that we've wanted to get on our agenda for some time now, because we realize that there are many, while there are many differences in our work, there are also probably just as many similarities in the need for us to closely coordinate our efforts so that what we have combined makes logical sense. I wanted to throw this open to our council members to see if you all had specific questions for either Helen or Katie. We've got them here for a little while, and we would just love to tap their expertise a little further.
Greg, this is Nancy Murray. I don't have a question, but I want to say, first of all, thank you. And I just loved the specificity of almost every one of your recommendations. And I think that is going to be crucial for the RAISE recommendations as we go forward, that we be very, very specific in what we're asking for. I also liked your use of the by 2025 date. I think that adds, at least, hopefully it will add to Congress members the need that these are important issues. We can get this work done in 5 years, but family caregivers can't wait much longer. We need these supports now. Even 2025 seems so far away. But again, I like the specificity, and I ticked off a lot of your recommendations that I think we need to include in our report, maybe phrasing a little bit differently. But there's so much in common that I thought it was just great. So thank you.
Thanks, Nancy.
Hi.
Go ahead, Alan.
Hi, Greg. I just want to echo what Nancy said, every bit of it, but do ask a question. How did you determine, or what were the driving factors that made you set the time frame at 2025?
So the legislation has the advisory council sunsetting in 2025. As I said, it began in 2011. So that was quite a timeline to look out for. And I won't give a great history of it right now, but there was a lot of interest and, how can I say this? Like political motivation, like the groups in the field were really pushing everybody, that kind of politics, not the other kind of politics, to set a specific timeline for preventing or for prevention or treatment of dementia. And so it was early on into the planning phases that HHS was able to commit to the 2025 goal for the first goal to address and effectively treat Alzheimer's disease by 2025. And that there's been quite a lot of debate over time about what the appropriate year is for care and services. But the group has sort of come to a consensus that there's no reason why we can't set 2025 as the goal for all of the things that we want to achieve. Even if we do have a treatment by 2025, there will still be people who have the disease and who are living with it, who we need to, whose care we need to meet and do a better job of meeting their needs.
Hi,
Deborah, go ahead.
This is Deborah Stonewalls, and I echo Nancy and Alan's sentiments. Thank you very much for your report. I'm wondering, was your recommendation to expand the FMLA Act, was that more specific in your report, or did your group have some ideas of how you'd like Congress to expand that? I was just curious about your thought process for that recommendation.
Katie, were you on that call? Do you recall?
No, and I think that this is an example of, I would have to go back and reread that specific bullet, but this is a real example of having the collective expertise as part of the subcommittee. So many individuals will bring their own knowledge base to help us craft the recommendations. And I think that some of the recommendations are more specific than others, right? Like you heard me read to focus on one specific piece of legislation and to work on that, whereas other times, like for FMLA, we're saying to expand it. So some of our recommendations, as Helen pointed out, have had to evolve over time. And the way that we work on the recommendations now is we have the privilege of having the ones from the year before that we can look to and say, okay, which ones now do we need to expand on? So I imagine that would be one.
And Deborah, so it was kind of a great question, and then I think we'll go to Diane, who may have a question. But to speak to both Nancy about the specificity and the measurable and how measurable your recommendations are, that's that knowing that how that was with Napa is what drove us to craft the agenda for our meeting today, which was to refine our goals a bit more, to make them more measurable so that we could, when it comes down to recommendations and then below each recommendation, specific actions that can be taken, that we can put those specific metrics or timetables to them. So that was, we felt we had to take like a half a step backwards in order to be able to take it that much further. And so that's going to be, you know, a part of our exercise today. And then also, you know, just to say, the recommendations that we're going to begin workshopping in subcommittees this afternoon will be your first shot at recommendations. And so they may be very broad until we get some experience and some time behind them to then begin to really hone them down and narrow them and focus them. And, you know, one recommendation may lead to 2 or 3 others a couple, 3 years from now. You never know.
And that is a good place to turn to your federal colleagues. I know some of the RAISE feds are not the same as the Napa feds, but certainly the folks who overlap. I can think of a case where we had recommendations that were for a specific agency added by that agency representative, because they said, we can move this forward, you know, make this a recommendation. It helps make it easier for us to advocate for funding within our office, and we're committed to this issue. Yeah. So that's a place to look to your federal colleagues for those sorts of commitments, and to help figure out what is doable under existing authorities and where it would be appropriate for Congress to take action to move things forward, or the states where the policy levers are at the state levels. And I think I mentioned before, it was challenging at first, but it's become a really productive relationship, and our specificity of recommendations reflects that that we're working together.
Thank you, Helen. And that's actually how Wendy and I are seeing this process unfold, is that once the RAISE Council is able to come up with their initial set of recommendations, we would then most definitely be working with not only the federal members of the council, but even reaching more broadly within the federal government to see, what could each of our federal partners do towards realizing each of those recommendations, and by when and what mechanisms. That would be our first layer, and then looking to what states could do, communities can do, the private sector, because as I've said before, this is a national plan. It's a national caregiving strategy. It's not a federal caregiving strategy. And so we are going to take that very much of a big village approach to this. Diane.
Great. I think you've all now kind of addressed this, but just to kind of put it in perspective, the Alzheimer's project has been ongoing for quite a while. So am I right in assuming that your initial report that you put out was probably very much broader in its goals and recommendations, and because you've had the years to keep updating it, it can become much more specific, so that we put our own report kind of in perspective? We can't get to the same level of detail perhaps in the first report that we may achieve later on.
Yes, that's correct. If you go to our website, I can't pull it up right now because I'm not the host of this meeting, but if you go to our website, you can find the 2011 recommendations, I believe, as well as the 2012 recommendations. And they were much shorter, and there were lots of them. I want to say there was like 30 recommendations. So over time, they've become much more specific, detailed, and sort of an overarching issue with the sub-bullets underneath them. So yeah, you can definitely take a look at those and how they have evolved over time. Even the recommendation, I think I'll just summarize, our number one recommendation was to increase funding for Alzheimer's research to $2 billion, which at the time it was 500,000. So, and it was in the middle of sequestration. It just seemed like a crazy amount and a crazy increase, and it wasn't backed up by anything. And so, various groups met, and different recommendations were made, and the advocacy community got together, and they had legislation passed that has now NIA, the National Institute on Aging, making a professional judgment budget, which we call the bypass budget, to spell out how much funding is needed to move forward towards our goal of 2025. So now we have a federal infrastructure for figuring out how much funding is needed to achieve that goal. And that was an example where we had a target goal, a target recommendation early on, and over the years it has evolved over time. I'm happy to say that our funding is past $2 billion now, but even that one recommendation has evolved and changed, and was many other different recommendations to essentially achieve the same thing.
And so I think what we're going to see today, when we break into subcommittees, after we refine our goals, you're going to see that right now, based on everyone on the council's work to develop the driver diagram over the past 2 or 3 months, Wendy and I were able to pull out, I want to say now, about 18 or so primary drivers to each of the goals. And those primary drivers are what you'll see as what we identified as could potentially be your initial set of recommendations. And then that number may go up or down based on the work that we do this afternoon, and probably in subcommittee meetings in September. So we're still very much in the evolution process, but I kind of think we're on track.
Greg,
yeah.
This is Nancy. I just have a very general question.
Sure.
Is our report also going to include specific actions under the recommendations?
No, that's going to come later with the national strategy. So our report, the way we're looking at it now, is the report would conclude with the broad recommendations that are going to be made. So however many we settle on, I think, like I said, right now we're around 18-ish or so. we would end with that, but then that would serve as the jumping off point for the next phase of our work, which is to take those recommendations and then develop the specific actions that can be taken, and by when and by whom. And that will become the heart of the national strategy.
Okay, that's very helpful. Thank you.
Mm-hmm.
Greg, a follow-up
Yes.
question to that.
Mm-hmm.
Will we name actors?
In the recommendations, we potentially could.
Okay.
And then, but certainly in the specific actions under each later on, we would want to. Say for example, some action under recommendation number 1, ACL will do this, but then there may also be a role for states and communities too, but in a slightly different way. And so that will be up to the council to determine that as well.
Thank you.
Helen and Katie, thank you both so much. We've been getting a lot of really positive feedback in the chat bar on the side. You guys are awesome. And Helen, I'll be coming to look for you for additional input and feedback.
Thanks, Greg. I look forward to working on this together. I care about caregiving too. So both of these issues are close to my heart. And I'm excited to work with you and work with everyone on this council to move both of them forward.
Great. Thank you so much. Okay, so let's go ahead and so that we can stay somewhat on track for this afternoon. Let's go ahead and move on to the next item in the agenda, which is Wendy and I are going to work with you all to refine the goals that we developed back in February at our full council meeting in February. As I had mentioned at the beginning of our meeting, when Wendy and I began working on the driver diagram, taking all of that information that you all workshopped in, I want to say at least 2 of your subcommittee meetings, it became apparent that as we look to develop recommendations, and then later the specific actions and strategies that become part of those recommendations, that the goals we had created in February were not exactly specific and measurable, at least not in a way that would allow us to later tie back to specific milestones for completion of specific activities. And so with that in mind, we felt that we needed to tweak our goals a little bit to ensure that we have ones that are more specific and that we can actually use to measure progress towards achieving them later on. And so in the prep guide that you all received last week, we laid out for you this first exercise, which was to provide you with the current wording of each goal, of each of the 5 goals. And then underneath that, we propose alternate or possible new wording for each goal. And the alternate phrasing is mine based on, my work in ACL and in managing grant programs where we work with grantees to develop and achieve specific measurable goals and outcomes. I took that approach in an attempt to give you something else to think about. And so then also, and this was based on a discussion Wendy and I had had with Alan Stevens, one of your co-chairs, was the amount of information and input that we had on the driver diagram really pointed to the necessity to pull out services and supports for family caregivers, to really give a focus to that and how we approach it in the national strategy. And so we are proposing the development of a new goal 3. So having a total of 6 goals, but we've put a new goal 3 in so that we could more adequately address the services and supports issue. And we'll get to that in a minute. So what Wendy and I would like to do is walk through with you the existing goals and some of the alternate phrasing that we have, and then just begin to have a discussion about each one of them. Are we on the right track with the current phrasing? Do we want to look at the alternate phrasing? So starting with goal number 1, the current phrasing is expand awareness, outreach, education, and access to programs, services, and products to optimize the physical, emotional, and financial well-being of family caregivers. And below that, I propose the alternate and pulling out or dropping in this particular goal the access to program services and products, because we pick it up again in the newly created goal 3. And then we offer this alternate new goal of family caregivers' physical, emotional, and financial well-being is optimized as a result of expanded awareness, outreach, and education. So keeping goal 1 more of the outreach, education, and awareness aspect of caregiver support. So thoughts on this, and we're going to have Chantal take notes as we talk, and hopefully if you want to wordsmith, we can wordsmith this goal if we need to, and move on to the next one.
And Greg, I'll just add what's nice is, so I love the way Alan laid this out with it, and as well as Rhonda Montgomery pointed out many months ago, because we had it all and we were so gung-ho, we put so many things in goal 1, but that there's a cadence to it. But you don't just start off with services and supports, you start off with an awareness. Then, and so we adopted both Alan and, or not adopted, but we're proposing basically what Alan and Rhonda Montgomery had suggested. And I think it just works out better. So anyway, thoughts on this, and then you'll see as the cadence goes with goal 2 and goal 3, that it's kind of the natural, more of a natural progression. And Alan and Rhonda, I don't know if you want to add to this.
I appreciate, this is Rhonda. I appreciate that you've kind of looked at that. I have another comment that is kind of prevalent throughout. As you've changed the wording from expand to, towards it, you've changed it to that it will happen, is optimized, which changes how we measure the outcome. I'm questioning, I'm not certain I have a choice on that, but I do believe that the rewording changes the outcome. One would we be measuring that our efforts indeed had gone in, and the second, we're measuring that our efforts have actually created a change. Is that making sense?
I think so. How would you then further tweak the alternate language?
Well, I'm sorry to skip you, but if you look at goal 2, it's easier to explain what I'm saying, and we can come back just for the wording.
Sure, let's go down to goal 2 quickly.
So you have current phrasing, recognize, engage, and support caregivers as key partners in the provision of healthcare. And that is, we're going to do this. But the alternate is family caregivers are recognized and engaged and supported. So one is we're taking the action, but we don't know if they're going to feel supported or become engaged. It's a nuance, but it does kind of change the way we think about outcomes.
Okay, so for goal 2 then, are you saying that the alternate phrasing is good? Or
I'm not certain which one we want. I'm actually kind of raising the issue that it's going to alter how we think about measuring outcomes. Alan, maybe you can, did that make sense to you?
Yeah, I'm gonna take a slightly different focus on it though. I tend to like the goals to be in a very aspirational state, and the recommendations getting closer to what you were saying, of they should be very measurable, and we should state them in which we could almost or try to identify a baseline and then progression over time. So I thought that might be easier to do in the recommendations than in the goals.
Yeah, and I'm not certain I'm taking a stance either way. I'm just raising it.
Yeah, no, it's a very good discussion, I think, and it gets to the importance of the interplay between, or the need to be very conscious of the interconnectivity of the goals and the recommendations.
Wendy, do you want to weigh in on this?
Well, it's interesting. I'm watching the chat feature, and Helen, do you want to weigh in on, because I think Helen's right. I think what we're talking about is in the current, under current phrasing, it's an active voice. In alternate, the verb, it's the verb tenses too. And one is kind of in a past tense. Helen, do you want to weigh in on this, especially since I'm sure you had to go through a similar type exercise with the Napa plan?
I had a quick thought on it. This is James Murtha. I guess my interpretation of this was that the previous phrasing sounded more like an objective, and what I liked about the alternate phrasing is that it sounded like the ideal, like the outcome of what we want, how we want to see like our work play out, like what the world is going to look like when we've reached it. Whereas the current phrasing is more like what we need to do versus like where we want to be. So that was my interpretation.
That's exactly right. And I'm just questioning, I guess what I'm saying, whichever we choose, I think every one of the goals needs to reflect where we want to go. So do we want the goal to be aspirational, or do we want the goal to be actionable? And actually the action has to come before the final. So I'm just raising, how do we want to phrase this?
This is Nancy Murray. I like the language in all the alternate goals because the first couple words of each of those goals are family caregivers. The emphasis is on the family caregiver. So it's very family centered.
This is Diane Caradu, and I agree with Nancy. I really like all the alternate because the RAISE group is supposed to be focusing on the caregiver. And so that's what this alternate wording does. I also agreed with dropping that access to programs and services and put in, you know, the new goal, but with the new wording and dropping out that phrase, I was just kind of left, it's optimized as a result of expanded awareness, outreach, and education to what? It seems to be, it needs a little something, and maybe that would clarify it a little bit better.
Yeah, the word optimize is a challenge.
I agree. And it's so when we think about, when we hear the big needs of family caregivers, most often it's, they need information, they need education, they need to understand what's out there, or they need to be actively outreached to in order to bring them into the system. And so perhaps the right word is not optimized. Perhaps I'm not really sure how we would show the ideal state of caregiver awareness, outreach, and education. I mean, what would be the different word for optimize that would sort of present us with the ideal world in this particular?
I like the word optimize in terms of aspiration. It's just difficult in terms of measurement.
Yeah, it is. I mean, it's incredibly subjective.
Yes.
Enhanced or elevated? Or...
I mean, enhanced is good. Elevated is enhanced is probably speaks more to quality, perceived quality anyway.
Can the goals be aspirational and then the recommendations and action steps be measurable?
So in how I view goals is, yes, they are aspirational. They're kind of like, if we had everything in our power, what would something look like? What is our ultimate goal? And then the next step under that is, well, what are all those smaller steps towards that goal?
Right. And are the recommendations and the action steps, could those be written in measurable terms, but leave the goals more aspirational?
Those are my thoughts exactly.
Okay. And I think when we get later on to the subcommittees and we begin workshopping the recommendations underneath the goals, you'll see that those are much more finite. They're a little more, definitely more finite than the goals, and they definitely would lend themselves to timelines, metrics, things like that. And then one step below each of those would be a whole series of steps and things that any part of the national framework could engage in.
And I'm comfortable with that. I was just trying to get us to have this discussion so that we agree what we're trying to do, because some of the things that are now in the goal would be very difficult to measure. But if we take it the other way and we can actually measure if we've done, taken the actions, and we're comfortable with that, then I think it's very clear and it makes all the wording easier.
What about if we changed the word optimized to improved or increases? Is increased or improved?
I like the increases.
So Greg, this is Carol. I like the word. I'd written down measurably improves or measurably increases, which takes into the account that we're going to measure that along the way.
Okay. Yeah, and we definitely do. Putting in measurable. So, Chantal, can we go up to the alternate and let's see about is measurably improved or measurably increases? Yeah.
I like this because, as everybody has said, with the goals, those have to withstand the test of time. And so they can be broad enough, because underneath those, we're going to have recommendations. And underneath those, we're going to have that action plan, very concrete action plan with concrete steps. And it has to, just like that Napa plan, year after year after year. So if we make the goals broad enough that it doesn't, stifle the council, and it allows this, but I love measurably improved or increased. Not sure.
Should we put in the word public in front of awareness?
I think so. Public awareness.
So on this, Alan, we might want to hold only because I think in this we're also talking about public awareness and then also caregivers' own awareness.
Yeah. Okay. That helps if it's both, because right now I couldn't define which one it was. So as long as it's included as both.
And I think when we get to the recommendation workshopping, you're going to see a separate recommendation for caregiver awareness and one for public awareness, and then how would we begin to address each of those aspects.
Perfect.
So are we so it looks like we've kind of settled on the alternate wording with those additions. Family caregivers' physical, emotional, and financial well-being is measurably improved or increased as a result of expanded awareness, outreach, and education.
Yes.
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 Okay.
Yes. Yes.
All right.
Hey,
We're going to get.
Greg,
yes.
this is Alan. Can I go back to, because this is another issue I think will be easy to fix, but gets a little clumsy later. In our guiding principles, we do a great job of defining family caregiver, and then we and then we really define what we mean by a care recipient as well, but we don't state it in that principle. And then suddenly, as we go through the document, we start using the term care recipient. And I felt that problematic when we never really defined it up front. So as easy as in the principle saying, or individuals who are caring for individuals, in parentheses, labeled or called care recipients in our documents. Just something early on or somewhere that describes what we mean by care recipient. But that's just a footnote. We can do that later. But I do notice that all of a sudden we start talking about care recipients.
Okay. All right. That's helpful. We'll make a note of that and then revisit as it becomes appropriate.
This is Helen. Is there a way to make it active voice so it's not passive voice? I feel like thinking about other national plans and HHS strategies, and sorry, I've got a little one here, but the active voice would be appropriate because these are things that we're going to undertake.
I agree with that.
Definitely. How would we, got a suggestion? would it be increase family caregivers, measurably improve or increase family caregivers physical, emotional? So put the measurably improved and increase at the beginning rather than starting with family caregivers. Would that make it more active?
Yeah, I think that would work.
But then we lose the focus
Mm-hmm.
on family caregivers.
Right.
That's what I had said before. I like that all the alternates began with the words family caregivers or family caregiving. That being family centered, they're the focus of this whole work.
Well, this is Lisa Wire. So does it mean that with the family caregivers being the focus, that they are the actors, they're making these things happen, or somebody else is engaging in the action that's going to benefit the family? Talking about the difference between the active and the passive voice. Who is the actor and who's the recipient?
I think
Sorry,
part
Alan.
of that is the difference between the two, because the current phrasing is active. And when, we're going to do these things, and the second phrasing is, this is what has happened. So I do think we get caught back in that issue of, is this the outcome or is this the action?
This is Lisa once again. So this is a question I think for Helen too. The HHS, when these will go through the agency, well, the Department of Health and Human Services clearance, will they change the voice from passive to active? Because I know that that's something my agency would do for the clearance process.
That could very well happen.
Couldn't you change this? This is Diane. Family caregivers' physical, emotional, and financial well-being will improve and increase as a result of expanded awareness, outreach, education.
Will measurably, yeah, will measure as, yeah. Oh.
And then we start with family caregivers, and you have a positive action, an active voice.
Thoughts on that?
That's okay too.
Yep, and that makes it active voice.
Yeah.
Okay. So for now, we're good with family caregivers' physical, emotional, and financial well-being will improve and increase as a result of expanded awareness, outreach, and education. We could even say
both?
measure. What's that?
Do we need both improve and increase?
We could are we trying to improve things, or are we trying to, I think we're trying to improve things.
You might only need improve because and not increase, because we have expanded.
Mm-hmm. Yeah. Okay.
Expand and increase are basically the same thing. Right?
Yeah.
Okay. All right. Okay, so it looks like we've got the revised alternate language is what we'll go with for goal 1. Now, goal 2 here, we get into the engaging with the healthcare system, health and long-term care system. And so the current phrasing is what you all voted on in February, and then the alternate is proposed as a way to, again, make it family-centric first, but then also sort of the aspirational.
So Diane, would you change that so that it's the same kind of verb tense? Family caregivers will be recognized, engaged and supported?
I like the language the way it is right now, and it's, I think, pretty straightforward.
Greg, this is Alan. I hate to interrupt, but I just wanted to bring your attention to comments from James Cheeley in the box, in the chat box, that I'm not sure we have addressed his issues for goal 1 yet.
Okay, Mr. Cheeley, can you unmute and talk about what you mean when you're saying that if all we want is improvement, we're not setting the bar high enough?
In an earlier box, he said he didn't have sound.
Oh, okay, all right.
He didn't have a microphone, so that might be.
I can attest to what he's saying, just because, like, improving is so gray. Like, you can improve at any margin. Like, even giving a family like $2 more a month in like aid, it's an improvement. But optimize is good for, like, a best case scenario. So that's how I feel. The most important thing is consensus among the group and managing the time that we have together. So getting the language straightened out, like, it's important, but also, like, I want to make sure that we get to all the goals. But I do see what James means by, optimization being like a word for, like, for the best case scenario.
So what if we were to look at putting back the word measurably, since for each family, improvement would be perceived differently? What James, what you think would be an improvement in supports for family caregivers may be, you may have a far higher expectation or a lower expectation. So if it's measurably improved
or meaningfully.
And just 1 second, Greg, I have requested James Cheeley to unmute, so he should be able to unmute.
Okay.
Got it back again. Yay.
Oh, good. All right.
Sorry. I was searching for buttons everywhere. I just couldn't find the right one. I look at this like a baseball season, okay? My goal in a baseball team, is it simply just to be able to play, or is it to win, or is it to win my division, or is it to win the championship? Okay, if all we set is a goal as to we're going to play, that's all we're going to get is we're going to play. I think our job as this committee is to make family caregiving the championship, which means set it up there where, the young lady before said they asked for $2 billion and they thought they were nuts. Okay, set our goals to where you're going to think we're nuts, but that's where we want to be. That's the significance of where we think the goal of family caregiving ought to get to, not just, let's measure a difference. That's me. I'm sorry.
No, I totally agree with you. And actually, what you're suggesting is what we're going to get at in the next level of our work, where we come in underneath these goals with specific recommendations. And that's where so when we say, for example, in goal 1, meaningfully improve or increase whatever, the next level down is, and this is how we're going to do it. We are going to increase X program by $2 billion to do more of X, Y, and Z. That's where we get into the specifics of the broader goal.
I see what you're saying. However, if you as the group getting ready to play a game, set your expectations after you set your goals, you never get to those expectations because you didn't set your goal high enough. They get together the first time, and my goal is to win the championship. Not, well, let's just put something out there and then maybe we can set that as our recommendation. I'm not a politician. I have nothing to do with government, but I think you're going to hand this report to somebody, and if they got to get to your recommendations and your goals aren't set high enough to begin with, I think you might lose their attention before you ever get there.
So do you have alternate wording for this goal that you're thinking about, that you have in mind?
You want me to be everything? Come on now. I'm just.
Oh yeah.
I just get shoot my mouth off. I have an answer. No, I don't have any alternate. I just am sitting here listening and was bothered by the fact that I don't think we shoot high enough in our goals. We need to be sure that that's to me, the first push is your goal, and you've got to set a high bar as to what you try to obtain.
Okay.
And improvement just doesn't seem like a high enough bar. And I see Carol's hand, so please help me, Carol, because I'm in trouble.
No, I love it. I love your aspiration. I love the energy on it. I was thinking about Alan's comment about meaningfully, and that kind of reflects the language from the age-friendly health systems, you know, for any health system, where you're talking about what matters to that family, what matters to that individual. And so meaningfully, to me, gets back to what is it that matters to that caregiver, to that care recipient.
Yeah, that's why I like that. And I guess, James, to go to the extreme, maybe the goal would be, you know, family caregivers will face no physical, emotional, or financial harm or upset as a result of family caregiving. I mean, you know, that's kind of the ultimate of there's no negative consequences to caregiving. But I don't know that we could state something that way. But
Yeah,
that's kind of the most aspirational.
I like meaningful. And again, although I really, you know, I admit what James is saying, in the long run, what we're being asked to do is produce something and then show that we succeeded at it. And optimize is just a problem because what's optimal for me might be very different than what's optimal for somebody else. But which is meaningful too, but optimize is just, there's such variation in caregivers. And so I like meaningful improvement because increase may not necessarily be true for some people either. Sometimes that's not right. So I really like that suggestion, meaningful improvement.
Okay. So if we go up to the rephrasing, the alternate phrasing for goal 1, will meaningfully improve. So realizing that we may not be able to get to the ultimate, what Alan just shared, caregivers will have no negative impacts, but that we can improve things, we can meaningfully improve things, and meaningful improvement then becomes an individual perception of what's better for me or has improved for me. Do we think we're at a place with the revised goal 1 that we could work with that underneath the alternate phrasing as we've got it worded now, could we come up with some very aspirational steps that would get us to that? And I think we can, and I think you'll see that when we get to the recommendations portion of our exercises, where you can begin to think about all of, the really big aspirational things that you want to do.
I like the meaningful improve because it also takes into consideration that a caregiver has especially if as many do over a long period of time are the caregiver, their needs are different. Their physical needs may not kick in immediately. Their great health and whatnot, they get tired towards the end, or the financial needs. So they're going to have different needs over their period of caregiving, and it needs to be improved each time. And the information they need will be different over time also to meet those needs.
Right.
I like it.
Other thoughts
Well,
before
I would say, like, regardless of what we put as far as optimize or meaningful or improves, it's all going to be subjective. And I think where we can get specific to, like, include meaningful optimized improvements can show up in our recommendations, like which fall under the goals. So I think, it's right that we're giving attention to it, but I think the specifics of what gets optimized can show up in like the ultimate strategy that we hand over at the end. But and not to discount the power of setting a compelling vision for yourself, because that is valid. So
okay.
I don't want us to sell ourselves short. There are some great people that have put their time and effort in thus far to this panel. Don't sell ourselves short. There's a whole lot of things, even in recommendations, that we can still do and make improvements with. When I saw that phrase, improve, our Kentucky Medicaid office is constantly handing folks in the disability community things that they say are going to improve our quality of life that haven't come close to doing that. It's just not enough sometimes to say all we want to do is improve it for me. But as a group, let's don't sell ourselves short.
Okay. All right, so let's go, if we can, let's go down to number 2, because I think there seemed to be more consensus on the revision of goal number 2. So family caregivers are, the way this alternate is rephrasing is sort of presents the end result of our work, or of all of that. If all of the recommendations we wind up making, and if all of the action steps that are proposed are done, then family caregivers are recognized and engaged and supported as key partners in the provision of health, health and long-term services and supports.
What's nice is this also dovetails really nicely with the Napa plan. We have something very similar with engaging family caregivers.
I really like this. My only comment was in the provision of care, and is that the right phrase to follow? Partner, to me, it's a partner, a person, and provision is a thing. So my only suggestion would be to consider removing in the provision of an insert with all providers.
Or our key partners with
all providers, or
with health and long-term service providers,
I like trying to get the actor in of the two. It's the family caregiver and it's the providers. It's not just the provision, but they're real people that really need to be engaged and partnered.
Our key partners with health and long-term services and support providers?
Yes.
Like partners in the discussions and provision, perhaps?
How about in providing, and make it active, are recognized, engaged, and supported as key partners in providing.
That makes it sound like they're providing.
They do sometimes.
They actually are providing.
I want the pressure here to be on the professional providers. We already know the caregivers are providing, and I think the pressure should be put on the
system,
professional sides. Yeah.
So you could either, Alan, go after key partners, you could say with providers of, and then healthcare.
Yeah, that's what I like.
Yes. I like that.
Okay. All right. So our key providers, our key partners with providers of healthcare and long-term services and supports.
I like that.
that's good too.
Okay, so we have consensus on the alternate for goal 2.
Well, and I like that we use recognize, engage, and support, which are 3 words of the RAISE Act.
Mm-hmm. Okay.
Now, somewhere we have to use assist and include, and then we'll have used them all.
I think that's coming next.
Okay.
And technically this is including.
Mm-hmm. Okay, so it looks like we have consensus on the revised goal 2. Let's move down to goal 3. And this is the new one. Okay, this was, we plugged in a new goal based on our discussions around the driver diagram, and we've proposed 2 different. So since this is an entirely new goal around services and supports for family caregivers, we have option 1 to consider, because you all haven't seen any of this before, or an alternate. And so I throw that open for discussion.
This is Diane. I like the alternate, but I would add after support needs of care recipients, since we have caregiving situations following that.
So you would put of.
Yeah, which are flexible to meet changing support needs of care recipients and caregiving situations.
Oh, support needs of care recipients.
Yes.
Okay, and caregiving situations.
Yes.
Okay.
Can I offer a friendly amendment, Diane, to say that are flexible to meet the changing needs of caregivers and the care recipients?
I like that, Carol.
Yeah, that would be better. Yeah.
Changing support, changing needs of,
caregivers and the care recipients.
Yep.
Can I offer that the word which should be that, as Carol suggested?
Yes. That are flexible. Yep.
Can I ask the question?
You can.
Should the availability of services, even though the situations be different, should the availability of service be the same for everyone? If for example, in the disability world, we had a vision somehow or the other for family members to be reimbursed for expenses of care, but that same reimbursement wasn't available in the world of Alzheimer's and dementia. Should it be?
So you, in addition to access, you want more uniform availability or more total availability to access and availability?
I'm wondering if that's part of what we as a group see as significant or not. I'm not looking for my want and desire here.
Mm-hmm.
Or more consistency?
I think the notion of flexibility kind of speaks to that, because we're talking about caregivers and we're saying it needs to be flexible to meet each caregiver's situation. So I think uniformity isn't always good, because what one person needs, the other doesn't.
I don't disagree with that statement, but I just want to be sure that services such as respite are available across every avenue of family caregiving, not just oh, you can get it, but I can't.
Mm-hmm.
I think that's in our principles, isn't it? Or am I missing that?
Well, that's actually going to be in the recommendations that we begin formulating underneath this goal. In the exercise that follows in the subcommittees, you'll see that we have things that speak specifically to the availability of respite services and education services. We get into the specifics of what it means to provide services and supports.
James, would a comprehensive
Would-
would a comprehensive array of consumer-centered programs, would that word comprehensive array, would that address, you know,
This is Alan. I think what I'm hearing from James, and I think important too, is we address the different populations of care recipients. So the changing needs, I'm going to just say something, changing needs of caregivers and the changing needs of caregivers regardless of the age or disability of the person being cared for.
Actually, I have an idea instead of.
But I don't know if that, James, if that's getting close to what you're saying or not, but.
James, instead of all those words, maybe what we need is before the word array, put the word equitable. So access to an equitable array of and then the whole rest. Would that address it?
I'm just a poor old farm boy in Kentucky. I don't know how to fix it. I just know how to.
This is Catherine. I think that it's more, I'm leaning towards what Jim is saying. It is not just equitable. You know, we have to address the fact that there is such a diversity in the care recipients and the caregivers. So I would like to, and I think that's what, if I'm hearing right, that's what James is saying, that, you know, we're not just talking about this is a profile of a caregiver. The profiles are so different. So somehow that has to jump out at us when we're looking at it, attempt to have flexibility. Because I'm here to tell you there's some folks, for some of these diverse care recipients and caregivers, they're not getting it because the profiles or what people think they should be given is a package deal. Just my comment, just my say.
So
Thank you, Catherine.
Can I have,
This is Deborah. It also comes.
I have 45 seconds, so let me try to summarize what I'm.
Sure.
Go ahead, Deborah. I'm sorry.
That's all right. I see it
To me, it goes back to that example.
You go ahead.
To me, it goes back to that example we talked about last time about a house. Okay, it's a great big house that we're trying to describe here of caregiving, and inside that house, there's a bunch of rooms. There's a veterans room. There's a dementia room. There's a disability room. There's a, you know, all of those rooms. I just want to be sure that every room in the house gets the accessibility to the same thing, even though it may not be necessary in your particular situation. We should all have, the House of Family Caregiving, should all have the accessibility to the same thing if we need. Don't just say, well, your family caregiving shouldn't have this, your family shouldn't have this. Let's all fight for the same thing under that roof of our house together, trying to be sure everybody has the accessibility to the services that they particularly choose to need, but they should all be the same.
So it kind of, as I'm hearing you, James, correct me if I'm wrong, but those different rooms are different funders. So VA pays for one thing, Medicaid pays for one thing, Older Americans Act pays for one thing, and those things don't line up. So while Medicaid may allow, or certain states may allow for reimbursement of family caregivers, that is not necessarily an allowable thing under the Older Americans Act services. So is that what you're saying, James? It's more of a funder issue?
I guess I think of it from my own family. I have a child with a disability. If I can obtain a service as a family giver for my child with a disability, and then all of a sudden my mother acquires dementia and I now become a family caregiver to my mother with dementia, why shouldn't family caregiving all be the same? And if I could get it from disabilities, why can't I get it because she has dementia? or get it because my nephew had gone to Iraq and got his leg blown off, and now I'm providing care for him. Well, why isn't the ability to obtain the same things available to everybody that's providing care? And I've chased us way down a rabbit hole. I'm sorry. It wasn't my intent by asking the question. But I think it ought to be the same for everybody. Sitting in chairs, they should have accessibility to the same thing without having to go, well, I know so-and-so over here was getting it because they were doing family caregiving. Ought not to be that hard.
James, this is Sarah Markel. I'm wondering if instead of equitable, what you're getting at is the use of the word universal, a universal array of programs.
I like that.
Or should be universally available.
Mm.
So family caregivers have access to a universally available array.
Or just say universally available consumer-centered programs, supports.
Yeah, have access to universally available. Yep, have access to, yep, that are flexible to meet the changing needs of caregivers, care recipients, and caregiving situations, or just caregivers and caregiving situations?
I just like of caregivers and care recipients.
Yeah, that's what we
Okay.
said.
All right, okay.
I don't want to throw this word in now, but I want us to, at some point in the recommendations, use the word reliable, because you can have access to services, but if those services are not reliable, so for in-home nursing, it's almost impossible to get.
Right.
So I don't want us to forget that word reliable.
Okay, and I could definitely see that concept of reliability coming in under here as a recommendation for how we look at quality.
Yes. Yeah. Okay.
So
it's good.
Are we at a point for this new goal 3 that we're going to go with family caregivers have access to a universally available, to have access to universally, getting rid of the word and, yeah, to universally available consumer-centered program supports, goods and services that are flexible to meet changing needs of caregivers and care recipients.
This is Helen. Based on our experience with Napa, I worry a little bit about making this too specific. I totally hear where everyone is coming from, but if we were to put this in the national plan, which, hopefully these goals will be what winds up in the national plan, and Congress did not act to implement a universal set of services because the funding mechanisms and streams are different and the authorities are different. And in many cases, the committees on the Hill are different and the legislation is different. So it's actually a pretty big ask to align these things. Like the Department of Education provides a lot of supports for children with disabilities, whereas it might be Medicaid for a different population. Anyway, all those things aside, I worry that if we were to put this in the plan, I don't know what the federal government could commit to doing in this space that would meet this very aspirational goal of something universal. And so short of a legislative action, could ACL doesn't even have the authority to do a universal program. So maybe think about ways to set an aspirational goal, and certainly the recommendations will be aspirational, but there might be some slippage when it comes to the national plan, or we might think about how to modify these for that national plan or strategy, just so that we can show that we're working on this, even if we don't get the things that we need to do it because we don't have the authority to. Does that make sense?
Yeah.
Helen, I hear you, but I hear what you're saying. I don't like what you're saying, but not directed to you, but just with the idea of not achieving what we want. Maybe, just maybe, a compromise. Could we bring this concept to goal 6 in which we talk about alignment across the different programs and coordination of federal programs?
Alan, this is Lisa. I think that makes sense. But for our colleagues on the phone who are not feds, Helen, do you want to explain what you mean by authority? I think it means that sounds like it's something that we don't want to do when actually it's comes from above.
Right. So
Go ahead.
I lost you a little bit there, Lisa, but yes, you know, the federal government is implementing the laws, essentially, back to Civics 101. And so CMS can only do what they have the legislative authority to do. And we're sort of bound by what our legislative authorities are. And so in this space, it's great, we've got caregivers representing a lot of different perspectives, but the legislation that governs the programs for the care recipients that you're caring for is all different, has different funding mechanisms. As I said, it's in different subcommittees on the Hill. And so it's just challenging for us as feds to move things forward without the authority to do so.
So for example, like if we want to write a grant or a cooperative agreement or anything like that, we always have to cite what the federal authority is that says that, for example, CDC can fund something like this, because it may be that ACL has the authority to do that, or the National Institute on Aging. So I hear what you're all saying and your frustration with it. Believe me, I think all of the feds on the phone understand and feel it too.
And certainly there's a place for it in the recommendations. It just might be harder to adopt as a goal because a goal in the strategy, because HHS does not want to release a goal that has no action steps that we can take underneath it. Or one action, you know, there needs to be a few action steps you could take towards that goal there, so.
Greg, this is Rhonda. Can I suggest that instead of using the word universal for the reasons that people are talking about, how about we say that are flexible to meet the diverse and changing support needs, or diverse, to use the word diverse rather than universal.
I was also thinking, like, instead of universally available, maybe like accommodating, like, but maybe like something like a little more powerful than that, but because
you know, it to me are flexible to meet the diverse and changing support needs, and whatever the rest of that sentence got changed to.
Yeah, and so we could say, we could go back to
leave support out. I think we got
the changing needs of caregivers.
Yeah.
Family caregivers have access to consumer-centered that are flexible. Yeah, to programs, supports. No. Yeah, just leave it right there, like that, for now.
Yeah.
What do folks think?
Greg, can you repeat that again?
So how it's worded right now is family caregivers have access to consumer-centered programs, supports, goods, and services that are flexible to meet the diverse and changing needs of caregivers and care recipients.
And then a reasonable recommendation, very aspirational under here, would be that there's a universal set of services available to all caregivers, regardless of care recipient conditions and, well, you know, everything else you would want to add in there. And you might say, you know, Congress should enact.
That sounds great, Helen.
Yep.
Yes, very good.
And that's how we get to the big aspirational things that we can then begin to, you know, that can begin to be advocated for, acted on, accomplished, and then we can, you know, check them off and come up with new aspirational recommendations.
Greg, this is Wendy. I
Mhm.
think we came through a breakthrough with this one, so that's
Mhm.
great. I think what we need to do though is looking at the time right now. We had a feeling that we might need a little bit longer, as it has turned out, to go through these goals. So, Greg, do you want to give kind of a heads up to that we're probably not going to be going to subcommittee meetings?
Yeah, this was when Wendy and colleagues and I were pulling this meeting together, we fully realized that this revising these goals and refining them and adopting a new one may take longer than the 45 minutes or an hour that we allotted to it. And clearly that's the case because you guys have so much insight into this and want to make this just right. What we can do, if you're amenable to this, and we've built in the contingency for it, is that we would spend the remainder of the afternoon until 4:30, whenever we get this done, and we would finish fine-tuning these goals. And then what we can begin doing is maybe talking about how you're going to workshop recommendations, but hold off on that until your September subcommittee meetings. Does that sound like a feasible approach?
Yeah, that sounds appropriate to me.
Okay.
Yes.
Okay.
Yes.
All right. So what we will do is we will then dispense with the breakout subcommittees later on, and we will just continue on until we're finished with these goals, and then we can have any final discussions about them, and then we'll go into what some of our next steps will be that we see, that Wendy and I see moving forward with our work, because we are really at a critical juncture here, given where we are with the report writing. We want to make sure that we have goals that you all are comfortable with and that can actually lead us to some recommendations that are big, bold, but also measurable and achievable. So,
can we still have a brief break?
Yeah, you can have a brief break. You guys, all right. So it's 2:52 right now by my here on the East Coast. Do you all want to take a 10-minute break or so and maybe come back at 3:05 Eastern? Take a little break.
We're coming back to this chat, right?
Yes, coming back to this. Just leave this open, and we will come back to this room at 3:05 Eastern time.
Greg?
Thank you.
Yes.
One moment, Cheryl.
Yes, hi, this is Cheryl. Oh, yes, I was asking if we could move to the other platform and stay in one session all together.
Why do we have to end this one?
Just at around 4.
Oh,
So you want to stay on here until then?
Yeah, well, we should be able to. I think we'll be good until 4.
Okay.
All right.
Perfect.
So we will resume at 3:05 Eastern time.
Okay, perfect.
Thanks, everyone.
See you soon.
Oh, I'm sorry. I think I can't talk on here because I'm live on the, no. Webinar platform for. So let's go ahead and reconvene, and I see others are starting to come back online, so that's great. So before we move on to the last 3 goals, I want to just pick up where we left off before the break. The alternate wording on goal 3 that we have here is family caregivers have access to consumer-centered programs, supports, goods, and services that are flexible to meet the diverse and changing needs of caregivers and care recipients. Are we okay with this wording as it is? Are we comfortable with that?
I have a question about consumer-centered. Consumer to me means business, and I guess I think about that would come at a cost to the consumer.
Okay.
And so I just want to be careful in terms of the language that we use in this case.
Okay.
Greg, we might want to use person and family centered just to be consistent with the principles.
Okay. That's a great point, Joe. Can we go up and just change, have access to person and family centered? Have family caregivers have access? No, down to the alternate one. Yeah, family caregivers have access to person and family centered. Joe, was that it?
Yeah, I mean, that would be more consistent with the find in the principles.
Okay. Any other suggestions for this?
This is Carol. After we played with the services, I'm missing array now that we've gotten rid of all the other words. I liked the array of services, which showed lots of different things as opposed to just services.
So have access to an array of?
Yeah, I kind of miss array.
Person-centered, person and family-centered?
So Chantal, would be access to, yeah, that goes above. Yep, perfect.
An array, and then we'll get James' version of the universal services in the recommendations.
Yeah, yeah.
Well, you can say to an array of flexible person and family centered programs, blah, 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 that can meet the diverse and changing needs of caregivers and care recipients.
Okay. That are flexible and can meet.
And I would like to say that of family caregivers, actually, because it's not just of the population of caregivers, but it's also within the lifespan of the caregiving lifespan, so to speak.
Okay. So the changing needs of okay, so then we have family caregivers in that one sentence twice, but that might be okay.
Diverse and dynamic and changing needs.
Melissa, I think the can kind of weakens it a little bit.
I'm cool with changing anything that will empower it.
But I don't know how others feel.
And meet, because yeah, can sounds limiting.
That meets.
Yeah.
That meets the needs.
And
I can hear you.
That are flexible and meets the need and meet.
I didn't check the verb subject agreement, but yes, I hear you, definitely.
Okay, and meets the needs of. Okay.
Do we need dynamic because we have changing? It seems like we have a lot of
changing and dynamic.
All in there. Yeah.
The diverse and dynamic needs.
Yeah.
Okay. Okay, are we okay there?
Meet the diverse.
You got the needs twice, yeah, that are flexible and meets the diverse and dynamic needs. So you can get rid of the needs
Okay,
of.
yeah. Yep, okay. The diverse and dynamic need, okay, yep. Okay, any other input on this? Or are we good with this? Are we good to go with this?
I think you can get rid of, just as a small thing, the S off of meets.
Okay,
Yep.
okay. Okay. Are we good with this? And then we'll come back and take a final vote on this one. So this is the new goal that we've added. This is our technically our 6th goal. This is the new one. It was not one that was here in February. And so this one begins to speak to the work that we're going to be doing and recommendations around services and supports for families. And we'll be taking a vote later on to adopt this as a new goal. Okay.
I hate to be such a nitpicky. I was thinking of an array of flexible person and family centered programs, because then you take out the that are flexible, because
Okay, to an array of flexible.
yes. Thank
Okay.
you.
To an array. No. Family caregivers have access to an array of flexible
Sorry,
person.
I'm my screen. Yeah, it's above. You have the to an array of
Flexible person. And, yeah.
It's already there. Yeah, flexible. And then you can take out
services that meet the diverse.
Exactly. That's
Yeah.
exactly right.
Okay.
That's, or at least in my seeing. Yeah. Thanks.
Right. Yep. Great. Yep. Just like that. Okay. Going once. Okay.
I like this.
Okay, cool. Let's go down to goal 4. And this is the goal that deals with the financial and workplace security issues. Again, what happened? Okay. We have the current phrasing, which is what you all voted to adopt back in February, but then through the work that we've done, this may require the need for a goal that's rephrased the way we show it here. So, thoughts? And y'all stop. Now you're getting shy after your break.
Yeah, crazy, right?
I know.
I think it's a good for starters.
The alternate?
Yeah. Yeah, I'm all for.
I would say lifetime financial security versus long-term, so that the family is okay after any caregiving and during, of course.
Yeah, I like that.
Yep.
I was muted up until the time you heard me speak, just for the record. I was
Okay.
having a technical issue. And so
No, I knew you
continue.
were there. I saw you. So.
I didn't see things.
Okay, so so it's looking like you all are moving towards the alternate wording with the edit that we made of adding and lifetime financial security. Other thoughts on the substance of this, the alternate wording?
This is Helen. I don't know if we want to promote employment.
Mm-hmm.
I don't really know what that means, but if it is the way that I'm reading it, I don't want family caregiver, like we don't need to force them to be employed outside of the home if they are full-time caregiving. So I liked it better with workplace security, but I'm not sure how to fix it to address that.
So, well, could we say family caregivers workplace and lifetime financial workplace security and financial security?
we already have this called financial and workplace security. There are
Mhm.
caregivers who have not worked outside of the home, and that would not be necessarily, that wouldn't address them. And so financial, I guess work is a
Well,
means by which their finances would be secured, a means.
well, I'm not saying dropping financial. I'm
Mhm.
just saying changing employment to workplace.
Well, this is Bruce. You could actually drop employment altogether, right? Because I think that's where, was that Melissa, where you were going?
Yes, that's right. That's
Yeah,
right.
because if we're financial security, there's sort of it delinks it from employment.
Mm-hmm.
And yet employment is definitely one pathway to financial security, but not a preferential pathway.
So are we talking about leaving out the entire notion of workplace?
Well, that was a big discussion because I know we talked about the fact that a lot of companies don't give.
Right.
Right. Yeah, I'm really hesitant to not speak to it at all because so many people, women in particular, are forced out of the workplace.
Exactly.
Yeah, I think it's essential. I don't think that financial security necessarily means workplace security.
Right.
I do see these as separate and related, and so it may serve to have two different lines. Work is healthy for people, who can, sustain a work life. And so the idea that there would be provisions in place for workers to maintain their employment while also providing caregiving.
What if we said family caregivers' choice to work and lifetime financial security is protected?
Can I maybe add that I think some of the workplace issues should be viewed not in relationship to a single caregiver, but more as a organizational goal that, we should want them to make these changes regardless if they have a caregiver currently working for them or not.
Mm-hmm. Right. So that's more of like a systems issue than it is an actual individual issue.
That's exactly my point. That's an organizational, institutional issue at the level of the workplace, right? And so the idea that there would be leave policies in place that would preserve.
Do we not think that it's feasible to have a goal that could encompass both of these aspects through right? So
I mean, workplace is important because there's discrimination when caregivers are working there and they take time out to talk to the home health or they take time off. I mean, it is a real issue in the workplace, which is in addition to other financial issues.
Yes, sick leave.
Right.
So it's about establishing a societal norm that values family caregivers even in their role of employment. But I think we're trying to impact a wider, we're trying to throw a wide net, which is really good.
So in taking what everybody's just said, if you go up to the alternate, are you all talking about saying, so you would get rid of choice of, and instead it'd be workplace. So family caregivers, workplace, and financial security, and then you get rid of the word promoted, to Helen's point. So because you're right, this is setting us up for, as you all were talking about, the leave, the workplace, flexibility. I mean, everything you've been discussing so far. So it has to be broad enough to have the recommendations that you want underneath it. So does that align better?
I just still think they're two separate entities or thoughts. That family caregivers' lifetime financial security should be protected and enhanced. and that means their services. We shouldn't tax them, overtax them with co-pays or whatever, a lot of things. And then we should say, and then workplaces should be designed to accommodate those who are caregivers. That's not good wording, but those are the two, that's how I separate them into kind of two different thoughts.
So to your point, Alan, but then wouldn't, if the broad goal is to speak to both workplace and financial, then wouldn't there be one recommendation under that talks about workplace design and work and policy, and then a second recommendation that would talk about steps around financial security, then with each having their own set of specific actions below those?
Yes, yes, that works for me. I just don't know how to word this to get to those two recommendations.
We think that the alternate wording, family caregivers, workplace, and lifetime financial security is protected and enhanced. And then do you think that doesn't speak to?
No, I think that works.
Okay, because then we can come in underneath this later on with very specific recommendations.
But the way that reads, it's the workplace that's protected. We're not protecting a workplace. We're protecting a person's employment.
Family caregivers workplace, it says, and lifetime financial security is the alternate.
Right.
So,
but again,
you've got the possessive form, family caregivers, possessive workplace.
Yeah, so we could.
I think it does say that.
So what we could do is, so security applies to both workplace and financial. So we could flip it so it's even more aligned. So family caregivers, lifetime financial and workplace security, so that it's in line with what we're saying at the very top of the page with financial and workplace security.
That works.
So then it's security of both, and to Alan's point, they are interlinked. Does that fix the problem?
actually, by having financial and workplace as you're proposing, that sort of decouples it, at least psychologically, in a funny way. So I think that could be actually effective.
Instead of workplace, maybe just job security? Or does that not really?
That's two different, yeah, I agree those are two different, that is different. But the workplace security is really important, but so is having that job. But that would be kind of enveloped. I'm not sure if that's, I'll let others wordsmith.
Is the phrase employment security, is that a?
That's what I was going to suggest, employment security.
Yeah, I like that. Financial and employment security.
Or could you put, to say it such that the financial security is the paramount, the lifetime. So family caregivers' lifetime financial security is protected and enhanced, including employment or job security, whatever phrase we want.
Do you want to say workplace flexibility and job employment security? And so the idea that there would be flexibility that would allow for accommodations for family caregivers.
One way to, this is Bruce, one way to think about that is that in the sub-actions underneath, you can get at the issues of sort of what does it take to create employment security, and certainly workplace flexibility is one of them. So I think some of this we end up detailing out in the sub, when we think back to the driver diagram again, sort of what are the secondary drivers or changes. And I just had one other, it's a minor change, but it may get to the comment before the last one. Family caregiver, lifetime financial security and employment security. So we're clear, we're talking employment security and financial security are separate concepts.
Right.
That might get the question of including, you know, the phrase, the comment about trying to, that might be another way to get at that.
Yeah, I like what you just said. And the employment security speaks to those who are self-employed so that we're not always working for someone else. We want to protect those people who are running their own businesses as well.
That's true.
Yeah, so if we go back up to the alternate, Chantal, and then put security after financial. Right. And council members, keep in mind that we were going to get to this had we been able to break into subcommittees. For every recommendation that you all propose underneath each of these goals, we're going to, you all as council members are going to be writing, and as subcommittees are going to be writing short rationales or backgrounds for each of those recommendations. So you're going to have an opportunity to articulate what you intend to have happen as in that recommendation. Following very much on the Napa model, we're going to add some definition to each of the recommendations, which you would ground in research or what have you. So these are just the big goals for right now.
I see comments in the chat field by the way of suggestions. I just wanted to mention.
Oh, I know. They're coming in fast and furious. It's hard to
I'm not
keep up with all of them.
keep up. It was just to bring it to your attention.
Yeah, and it should be stated for those members of the public, all of the comments that you're typing in are being saved. So they're not, once this meeting is over, it's not like they disappear into the ether. All of these are being recorded, so we'll be able to go back and see what has been suggested and commented on. All right, so are we okay with the alternate phrasing for goal 4, family caregivers lifetime financial security and employment security is protected and enhanced?
I would just change the is to an R. Or do you?
It's true.
I think it should be is, because it's financial security and employment security are both singular concepts, I think. Our editors will worry about it. Okay. All right. Are any other last attempts at, or runs at this particular goal before we move on to 5?
Looks good.
All right. Let's move it down to goal 5. Okay, this is the research, data, and evidence-based practices goal. And so you've got the current phrasing, which you all voted on in February, and then some modification to that in the alternate. So I will throw it open for discussion.
So this, Carol, I noticed in the Alzheimer's presentation that they use the word evidence supported as opposed to evidence based, which has, the connotation that a random control trial. So I thought that I liked that change. Even though I support evidence based as the highest standard, I liked evidence supported.
And where would it not be applicable was my question when I saw where applicable.
There may be instances where, not every intervention for a family caregiver needs to be based in research and, have the highest, the criteria that ACL looks at for implementing evidence-based programs, which, publication in a peer-reviewed journal, randomized controlled trials. Not everything is like that. We know respite's very effective, but the evidence base for respite is not very robust. So where applicable kind of qualifies it.
Do we want to maybe to keep it consistent with all the other goals, say caregiver supports are evidence-based, available for replication and validated with continued research as applicable? Or
sure.
That's good.
Right, and my recommendation had been to change evidence-based on the alternate to evidence-supported.
Even
Not
up
caregiver supports. Yeah.
Even up on the main goal, Carol, research data and evidence supported practices.
Yes, I think to be consistent with the Napa recommendation, that puts us all in this with using the same language.
Okay.
And Greg, I just put a rewrite in the chat box that it's kind of it's a bit of a rewrite, but I thought it important to get in there that family caregivers are stakeholders in this research process. And that what do we really want from the research? You know, we really, in my view, we really want it to document the real caregiving experience. You know, to get away from this as this should not totally be from an academic researcher's point of view.
Right.
I would almost like it to be from the caregiver's point of view. What do they think the research agenda should be?
And I love that. And would that's actually something I'm thinking would make an ideal recommendation underneath this goal, because then the way I'm seeing it, there would be multiple ways to begin engaging and making sure that caregivers are engaged stakeholders. Do you think?
Yes, I just think we have to really emphasize that.
Okay, all right.
That caregivers should be engaged. I really don't like the word applicable
and
either.
evidence supported. You all have taught, you know, to me that this is testimony to the importance of caregiver engagement in this process.
And then Joe, do you, what strikes me with the alternate is we don't have the word data in there. And I know with your presentation, we're in desperate need of better caregiver data. Do you see a point or where we need to maybe add the word data into the alternate? So it's not just research.
Yeah, I mean, I noticed that, but I don't have a good suggestion. I you know, it's this, what is the data on? And I mean, I did like Alan's comment about the caregiver experience, like, you know, and I think sometimes it's not always just the caregiver support, but understanding, you know, the caregiver experience through data collection. But I don't know, I'm struggling to come up with a good suggestion there.
Yeah, I'm struggling with this one a lot because it's so focused on caregiver support and basically ignores what the first recommendation is, which is more about surveys and population-based data. And to me, this is absolutely critical because this research needs to speak to policy. And the way it's written now, we're losing our opportunity to say we will have population-based research that can be used to inform policymakers. And that's totally lost here.
Is there a way, this is Helen, our fifth goal has to do with tracking progress. Is there a way to say and build the research infrastructure to track progress towards the goals of the RAISE Council, or however you would want to say it? Because that would address the survey data needs and help set you up to, you know, include measures that would get to some of the things we want to track for the other goals. We tried to make the other goals actionable. So, you know, tie it all back together.
So are you saying, Helen, that that we would, I guess, propose an entirely new alternate phrasing for this that makes it much more about the tracking and measurement?
I think, I don't know. I think you can incorporate the caregiver supports being evidence supported in the goal related to access to long-term services and supports. And here focus on, and I know everything is caregiver focused, so I don't know exactly how to get there, but you know, maybe this one is the one that's more research or federal government focused, and talk about building a research infrastructure to better understand the needs of caregivers, develop and replicate evidence-based caregiver supports and track progress on the national strategy or whatever.
Mm-hmm.
Yeah, I like the way that's going much better, because I think it's in one of the recommendations under goal 1, we specifically say caregivers should have access to evidence-based programs. So yeah, I think it overlaps several places the way it's written.
Mm-hmm.
And remember, this is called research, data, and evidence-supported practices. And so we're talking about only those things here. We're talking about programs and services outside of this context as well. But here we need to talk about, I think, what type of research, data, and evidence-supported practices, right? What the aspirational goals are here.
So we lost, I liked what Helen said that second time, which kind of mirrored Alan, what you had in the chat box a little bit. I don't know if we can go back to capture that.
Let me see here. Family caregivers is this that about family caregiver engagement in research, Carol?
Yeah, it was talking about building an infrastructure that looked at, understood the caregivers, the evidence-supported best practices, and it was building that infrastructure.
Yeah, Carol, what if you put the infrastructure part kind of as an introduction to what I put in the chat box? Maybe that would combine, or at least get us to a closer. That a national infrastructure is created that would engage family caregivers in research that documents the caregiving experience, da, 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 da.
Yes, I think that's close. I can't see your chat anymore, but
okay.
That's closer.
So can we go up to the alternate phrasing? And because Alan, I think what you're proposing is how we would begin to reword this goal, correct?
Yes.
Okay. So let's go up to the alternate phrasing, Chantal, and so what did you, a national, you said something. Oh, you're on mute.
Yeah, I'm trying to remember myself.
A national infrastructure?
Yes.
Yeah.
This is Lori. I'm not sure if this is the right comment, Alan. Family caregiver are engaged stakeholders in research that documents the caregiving experience, translates evidence into best practices, and develops new consumer-centered interventions.
Yes, I'm trying to combine the idea of a national infrastructure that would allow those things that I put in the chat that you just said. So I'm not quite how to do that in terms of a goal, but I think that maybe blends a lot of things.
Well, I think what Lori just read might get at what you're trying to propose. And Lori, can you read that again and Chantal type it and we'll see what it looks like?
Yeah, I think I can put it in the chat box again.
I just recopied it and posted it again.
Okay.
Should be at the bottom of your feed.
I'm going right from the chat.
And I did too. I just reposted it.
Yeah. Okay.
So Chantal, are you copying it from the chat or shall I read it?
Yes.
Okay.
Okay.
And then maybe add to that somehow or another, create a national research structure that engages family caregivers in research, da, 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 da. And that would just be at the beginning of what.
So family caregivers are engaged stakeholders in a national research infrastructure?
Yeah.
Infrastructure that documents their experiences, translates evidence that documents their experiences, translates evidence into practice, and develops new consumer-centered interventions.
I would add a third or fourth clause, I guess, which would be and tracks progress on this national strategy, because we're trying to retroactively track progress, and it's really hard. And I wish we could be able to add questions to surveys before we started.
Yeah, and it's person and family centered instead of consumer centered.
Yep.
Good point.
And then does that do enough with surveys for data? That data piece?
That's what I was trying to capture with the idea of the caregiving experience, or
in a national research and data gathering. And is it, would it be stakeholders in a national research and data gathering infrastructure?
Okay.
Yeah, great.
But that, I'm not sure, I think that that's very important, right? But that doesn't necessarily characterize the goal of the research and the data. That's, I think, a very good quality of the type of maybe.
So I think it's, we put goal 5, we put the header up there just to talk about the subject that we're talking about. So I'm not sure that it was to sort of begin to differentiate between the different goals of broad topic areas that they were discussing. So that those were kind of afterthoughts as a way of organizing things. So I think it's more important for us to focus on the wording of the goals and making sure that that there's something that we can actually develop recommendations to.
Sure. I'm thinking, though, I'm reading your alternate statement there, and I'm remembering also past meetings of ours when this has been discussed and people have talked about, the type of data that are needed about caregivers.
Right.
In terms of the economic impact on caregiving, all the other stuff, the health outcomes,
Right.
that's not captured as it stands in this statement.
Right. And so underneath this, when we begin developing the recommendations under this, is when you would have could have specific recommendations that talk to data gathering around health impacts.
Thank you for clarifying.
Yeah. This is we're keeping it very broad and aspirational here on these goals, and then the subsequent recommendations, however many of those, is where we get to drill down into the nitty-gritty of what we're talking about.
Yeah, Helen, can you say more about and tracks progress? I like that phrase, but as it stands here, I'm not sure what it's linked to. What is it tracking?
I would say
progress on what?
Tracks progress towards either the RAISE goals or the goals of the National Caregiving Strategy or something along the line. Tie it back to everything we've done previously.
Great, thank you.
And a quick question that was on my mind, and this, I think I'd be particularly interested for people who have been in the policy development side to weigh in, is just the one word tracks. Would it be a better choice to use the word evaluates?
Or monitor?
Well, I just think of the word evaluates as like, you track it and you decide if it's effective, whereas like tracking feels like, you're just recording, but not really doing anything with it. But
or how about measures? Measures progress.
I like that.
Because evaluating is a much more in-depth, complicated. When you look at pure evaluation versus tracking, they're two very different activities with varying levels of tools and processes, but it all falls under measurement, more or less.
Yeah. Thanks for the explanation, Greg.
Sure.
Good.
Are we okay with this?
I like it.
All right. Let's go down to the final goal, and this is our this is our infrastructure one, around program, administration and collaboration. And so you'll see again the current phrasing, which you all voted on in February, and then some proposed alternate language to get us started on this goal.
Can you say more about what's the meaning of the systems? I don't know what is the system.
I think it would be, and systems is probably the wrong word. I think, and Wendy chime in here, I think we're talking about programs, policies, policy development, legislation, more of those things that drive the like again, the administration and governance of and operation of programs.
Right.
And so system may be the wrong word to use.
I was bothered by, this is Diane, by systems also. So I deleted that and then added after activities among all appropriate stakeholders, which was in the current phrasing.
Oh, yeah.
No, after the word importance, put among all appropriate stakeholders. And take out the word systems.
This is Helen, devil's advocate here. Could we roll this into goal 1, where we're recognizing caregivers? I had to go back and find it. So not just having awareness, outreach, and education, but that this, including them as part of the, I'm going to say infrastructure again because I'm losing words, but including them as part of this and recognizing their role as part of recognizing caregivers.
I thought this was being left separate. Not a bad idea, Helen, but my memory was this was also separated out to get to the idea of this being a national strategy, not just a federal strategy, and that we were trying to work in the many different systems that were in play here. But I could be wrong.
Yeah, Alan, you're remembering correctly. So this would be to get at some of the, and you can do whatever, the council can do whatever it decides is best. But if you lumped it in with goal 1, you would have a lot of recommendations in one goal, because this is covering so many of the things you all have talked about around the pandemic, around state and local planning, around private public partnerships, around, I mean, there's a lot in governance and collaboration, because it isn't just, it's not just a governmental, they're not just governmental solutions. So it would be very large if it, it was put back in with a goal, which is why I got separated out a long time ago.
Yeah, and
I want to add in. Oh, I'm sorry, Alan, please.
No, I was just going to quickly say it, and I kind of thought this was our opportunity to really say how hard our task is, and that we're talking about caregiving across the lifespan, the universality that we were talking about earlier, that this was really a statement of this is a societal issue that is multifactorial, and we need to emphasize the importance of cooperation and governance and inclusivity. Probably the hardest one to write.
And so I wanted to take the word infrastructure and put it in a different way, but to make sure that institutional infrastructure is there, you know, and this could be at like federal, national, local levels that you're, you know, describing these, but that would not just build, but also, you know, encourage, promote, sustain you know, this society and to support the society that does this.
This also starts to the sort of the
I'm
impetus
giving an
behind
idea, not words.
the impetus behind this goal will start to become evident as you look at the inventory of federal programs, where we want to talk about reducing silos, about increasing collaboration, about developing plans and doing strategic planning at the federal, the state, the local level, area plans on aging that meaningfully include how they're going to support families and family caregivers. This is, to me, is kind of the unsexy part of family caregiver support. But it's things that are absolutely necessary that kind of help to form the underpinning of being able to actually implement a strategy.
So you can think about this as a means towards to the ends, which would be the other goals that have been outlined, which is, I think, how I was initially reading it and why I thought it should wind up in goal 1. I think if you're going to keep it here, maybe take out, and I'm pulling one of the comments out of the chat box too, take out long-term services and supports and, talk about their role in society, and the importance, of them to societal life or something like that would get at that a little bit, but so that it's clear that it's not just to make long-term services and supports work better. It's a broader thought about
a societal sort of a thing.
Yeah, agreed.
I like that.
That's good. That's really good, Helen.
Our linchpins of societal life. Yeah. Or of society.
Offensive. Sorry.
Well, let's see, are recognized as the as critical essential elements or essential aspects, essential components.
I would say family caregivers are the.
Yes, okay.
Well, are they important? Are they just important, or are they the focus?
I would say they are the essential.
This is societal infrastructure?
Yeah. Societal infrastructure.
In a way, family caregivers are the safety net. When you think about how we provide long-term services and supports for people in this country, they're the safety net. When there's no other long-term service or support, or there's no funding left, or there's no place, it's family caregivers who fill that role.
So
Nancy, I hear you, but I would almost turn it on its head of they really are the essential or the most forceful or most powerful group, and things like Medicaid become the safety net. I mean, it seems like they do more than what we would typically call safety net programs. But
so yeah, it's so are we at family caregivers are the essential linchpins, and it's LINCH?
Yeah.
Linchpins of societal infrastructure as evidenced. Get rid of life by actions.
Well, somebody said it before. Evidenced by legislation, policy development, and a national strategy. I think it's important that we mention legislation and policy development because the audience are legislators.
Right. Yeah. One of the audiences definitely is.
Right.
I'm almost wondering if we can use some of our our last guiding principle kind of gets at this point, and I'm wondering if we can use some of the words so we're consistent. So we're saying the national strategy that's created in partnership with family caregivers, it's going to be a living document that fosters cross collaboration and cross discipline. And it outlines ongoing actions to be taken by federal, state, and local governments, community providers, and others. It gets at kind of that whole administration and collaboration.
It seems like maybe we're doing a couple different things here, but this kind of essentialness, what if it was something like families provide the majority of care for care recipients, therefore, you know, something, because there's kind of two different thoughts going here. We're trying to like say that caregivers are very important, but then we're kind of using that as the rationale that means all of these other policies and administrations and governance things should get in line because they're so important.
Yeah, so
that's
sort
what's
of
getting jobbled.
So sort of going back to the whole notion of caregivers as the backbone of LTSS, family caregivers are, as you know, family caregivers are the backbone of our LTSS long-term services and support system, as evidenced by legislative and policy development, and I don't know.
I like separating this and going back to separating family and caregivers into families provide care. So it gets this, you know, more idea, more than, but I don't know why. I'm just trying to kind of get away from using family caregivers.
So here's a suggestion from the comment box, something to the effect of the essential value of family caregivers is demonstrated by legislation and government programming and services focused on their needs. We could tweak that a bit to say family caregivers.
How about should be demonstrated by and not is?
Yeah, should be demonstrated. Or
but this is a goal, right? So
right.
In the other ones, it will be demonstrated. You know, I'm looking at your time, and I'm wondering, this one is pretty complex. I do like some of that cross collaboration. I don't want to lose that. That was in our guiding principles. So I don't know if maybe some wordsmithing behind the scenes and then send it back to us for comments if we run out of time.
All right. We could probably do that. Because this was sort of that goal that was kind of hanging out there, that I think we need to have something that speaks to this, because as we begin to look at, one of the intents of the RAISE Act is to reduce duplication and redundancies in programming, but also to foster closer collaboration and among various sectors that could be involved in supporting caregivers. I think this type of a goal becomes essential. So,
Greg, just one last comment.
Sure.
Could this goal maybe be based upon the findings from the cataloging of current caregiving programs? Because it seems as though if all of that is happening already, maybe this goal is not needed, or maybe this goal needs to be crafted to make what's there better, stronger, whatever.
I mean, this is certainly a goal that could be added down the road in a subsequent update to the report or in an update to the National Caregiving Strategy. Once we have all of the information, I mean, that's certainly a valid point. We may not be ready for this yet. Is that what you're saying?
Yeah, I mean, yes. I just find this one impossible. I feel like I have nothing to contribute. This one is so hard.
Yeah, it really is. It really is. And we could agree to put this aside and table it for now, with the understanding that, you know, in a subsequent update to the report, you know, once we know more and once you as a council have had the opportunity to, you know, have more presentations from various sectors, that maybe something becomes more evident.
Greg, this is Alicia. I am just as perplexed as Alan. I do think we need, I really didn't understand some of what it meant or how it would be measured, because like others have said, I didn't know what systems were. So I didn't know how we would be able to measure what it was they were doing and not doing. So I agree that we should take some time, get a sense really of what it is, and then begin to use the kind of language that would get us into tactics, and after the goal is clearly defined, into tactics, strategies, and then how we can measure.
Okay. So if I'm hearing the feedback correctly, we should probably, we're looking to perhaps for now table goal 6, and not necessarily focus on it, at least in the first iteration of goals and recommendations. Is that correct?
I agree.
I agree.
Okay.
That makes sense to me.
Okay.
Yeah, agreed.
All right. Okay, great. Before we conclude, I want to try to get a couple of things on the record so that we can move forward. We had 2 polls ready to go. The first one we want to put out there is with the adoption of the new goal 3, which was the services and supports. So we're pulling that one up quickly. We have are you in favor of adopting this new goal 3 as written in the alternate? If you could just check yes or no. And this is again just for the non-federal members of the council. And just submit your vote, and then we'll see what the tally is. Okay, and okay, great. So we have adopted this new goal 3. The second poll was to adopt the revision of all of these, of the wording of these goals, the way we've workshopped them here. And I will add to this that we are going to, for now, drop, we're going to table goal 6. We're not going to eliminate it, but we're going to put it aside for now. And so if we can put up that second survey or poll, Cheryl, are we going to adopt the rephrasing of all of these goals? Okay. Great. So this is great. Now, of course, we didn't get as far as we'd hoped today, because we had hoped we could have just wrapped all of this up in 45 minutes and then set you to start to work on formulating some recommendations for under each of these goals. So fortunately, we built in the contingency that this might happen, and it did. So we will be looking to have the subcommittee meetings that are already scheduled for September. We're going to tweak the workshop assignment, the recommendations assignment, because we're going to pull out goal 6 for now, I think. And we will set up your September subcommittee meeting so that you all begin to workshop the goal or the recommendations under each of these goals. Then our plan is to convene as a full council again in October. And we're going to put up a quick poll to see the dates that we could possibly schedule for the next full council meeting. We're looking at either October 8th, the 13th, or the 14th. And if you could please indicate all the dates that you're available I realize you may not have your calendars open, and if we can't get a good enough sense, then what we'll do is we'll do a Survey Monkey to the council members after this. But if we could maybe get a sense for which day would be the better day for doing another full council meeting like this from about 12:30 to 4:30, during which we would hopefully present and then adopt a set of recommendations that would be dropped into the draft report. We can take a look at your calendars for that. Okay, so we have a fairly even split.
October 8th looks better.
Yeah, October 8th looks better for a full council meeting. What we'll do is we'll take this. We may look to do a second poll of everybody to see if there's any flexibility in calendars. So we won't, I guess, based on this, how evenly split things seem to be, we won't land on an October date right away, but our intention is to have you workshop your recommendations during September subcommittee meetings, and then in October we would convene again as a full council to have each subcommittee present their slate of recommendations, what they're going to put forward, and hopefully by the end of that meeting we could have a vote to adopt the recommendations, because at that point we should be far enough along in the draft of the report that we'd be able to drop those recommendations into the draft of the report. Does that sound like a feasible plan? I mean, we're making really great progress here. This is an incredible amount of work, and so I appreciate everyone's forbearance with this with the discussion. This was incredibly helpful. I'm energized by it. Wendy, did you have any last minute?
Didn't I just want to thank everyone so much. Hey, you did it. Got through the goals.
Yeah, and this actually revising the goals the way we did, I think will actually help make the workshopping of the recommendations in September hopefully a bit more straightforward, because now we have a set of very measurable, actionable goals that we can do. And Helen, you were right early on. You said things are going to probably change and evolve, and they have. And this is I think one of the nice things about this. In the next few days, you'll be getting a copy of the draft of the RFI analysis to have. I think that will be tremendously useful in terms of helping you think about the recommendations. And then we will send out a working, like a draft, a prep guide for your September subcommittee meetings to help guide you along and make sure that those meetings are very productive in terms of helping to fine tune and develop recommendations. Are there any last minute comments or questions from anybody?
Greg,
yes.
Would it be possible, because I didn't write down the alternate language that we finally came up with, those first 5 goals, just have the alternate language like sooner, in an email, and then
yeah, absolutely.
thinking about it.
Yeah, absolutely. Yeah, absolutely. We can do that. I mean, that'll be the one thing. Maybe we could send that out over the next day or two, just in an email. Here's the alternate. Here's the new goal phrasing that we adopted, so you can have that to think about. Definitely.
I was wondering, Greg, if in order to help us jumpstart the recommendation discussion, if we would be incorporating or mapping back prior strategies and specific actions that we had discussed in past meetings.
Yes, I mean, that's part of, one thing that we can begin looking at, is in the prep guide that you all got for today's meeting. Had we gotten to the subcommittee meetings, you would have seen some draft recommendations that Wendy and I put together based on all of the work on the driver diagram. We still plan to start at that point. Because even though we reworded these goals, I think those primary drivers that you came up with, that are actually form the basis of those recommendations still stand. But there may be others that you want to propose as recommendations, and we can certainly draw from that inventory of recommendations that Wendy and team put together. That's an incredibly valuable tool for your work.
Well, the prep material coming into this meeting, I saw that was lacking in terms of the efforts that we had done on previous meetings. So, and in order to help me through this and to prepare for this meeting, I did that mapping. It doesn't really take much effort. So I didn't know if we were losing all that information or we were going to be carrying it forward, knowing that we would be improving it and, you know, distilling it.
That information, meaning the big
the drivers, you know, the strategies, how are we going to accomplish this, and what are the specific actions or programs necessary?
Right, all of those. So the driver diagram, none of that has been lost. In fact, the primary drivers in that driver diagram are the recommendations that we had hoped to get to work on today. We carried those forward. And then leaving the option to consider others based on, you know, the conversations that we've had.
All right, great, thanks.
You're right, Teresa. So we have that driver diagram, we still have that, and you're right. So we have captured, so as you move forward, the prep guides will continue to link to that driver diagram with your very concrete recommendations. We didn't lose any of them.
Yeah, I think that'll be just a big help in terms of moving forward and completing the recommendations.
Yep, definitely. Any other questions or comments before we conclude? I just again want to thank you all so much for your time and your perseverance.
Greg,
yes,
this is Ronnie. I just, you know, I've been here the whole time, and I have watched the council work and the strategy and goals unfold, and I just really want to commend all of the people who are so participatory and who are, you know, adding their thoughts and their experience, and it's going to make this work so much better. I've been just really impressed with the group. So I wanted to make sure to say that to all of you, to the ACL folks and the NASHP folks, and really to the council, all members. Thank you.
Thank you. Well, I don't know about everybody else. Yes, go ahead.
And I just wanted to thank you and the assistant secretary and all of the ACL staff for bringing the video of Secretary Azar to us. I just felt that was incredibly inspiring and very meaningful to me as a member.
Thank you, and that'll be posted on the RAISE webpage along with everything else from the meeting. So it'll live on in perpetuity. So that's kind of nice, and it is amazing how far we've come in a year, and how much we've gelled, and how much I actually look forward to these. This is really good. It's exciting, and having been a caregiver for years myself, I certainly appreciate what we're doing here. There's deep meaning to it. So, all right, folks, we will send out the revised goals to you in the next couple of days so that you have those, and then be on the lookout for some prep materials and guidance for how the subcommittee meetings will unfold during the month of September. And we'll hopefully get back on track with our recommendation development then. So with that, we are going to conclude, and again, thank you all. Be safe and take good care.